Hi everyone, and welcome to our module on deletion syndromes. In this video, we're going to talk about a number of rare genetic conditions that result from partial deletion of a chromosome. So this is different from disorders where you gain or lose an entire chromosome. It's also different from disorders where you gain or lose a single gene. In this situation, part of a chromosome is lost. It may be the entire long or short arm, or it may be a portion of the long or short arm. Most of these syndromes are believed to occur due to errors in crossover during meiosis. In the video on meiosis, I explain the phenomena of crossover as shown at the bottom of the screen, where genes that are being duplicated exchange genetic material so that the end product is a mixture of genes from different chromosomes. What's believed to lead to some of the deletion syndromes is an unbalanced exchange of genes during crossover in meiosis, such that one chromosome ends up with extra genetic material or a duplication and another ends up with a deletion. Most cases of deletion syndromes are sporadic. In other words, they are not passed down through families. You'll see them referred to in textbooks as congenital. And the key syndromes that we'll discuss in this video are cases of deletion syndromes are sporadic. In other words, they are not passed down through families. You'll see them referred to in textbooks as congenital. And the key syndromes that we'll discuss in this video are Cri-du-Chat, Williams syndrome, and finally thymic aplasia. Cri-du-Chat syndrome is caused by deletion of part of the short arm of chromosome 5. So chromosomes have a short and a long arm. The short arm is denoted by the letter P, and for that reason, this syndrome is sometimes called the 5p- syndrome. Children with this syndrome have severe intellectual disability. They have cognitive, speech, and motor delays. The reason it's called Cri-du-Chat is because the infants will cry like a cat. It's classically described as a mewing, which is a high-pitched cry. This occurs soon after birth and then resolves. These children have characteristic facial features, which is shown in this picture on the screen. They typically have a small head, which is referred to as microcephaly. They have wide-set eyes, which is sometimes referred to as hypertelorism. They also have low-set ears, a small jaw, and a rounded face. Children with congenital heart problems. Our next deletion syndrome is called Williams syndrome. It's also called Williams-Beren syndrome. This is caused by a partial deletion of the long arm of chromosome 7. The deleted portion includes an important gene called elastin, which codes for an elastic protein in connective tissue. So children who have this deletion have what's called haploinsufficiency, meaning because they are missing one of their elastin genes, they produce insufficient amounts of the protein. Children with Williams syndrome have a facial appearance that is classically described as elfin. You can Google this and find lots of pictures online of children who have Williams syndrome, and you'll begin to easily recognize the facial appearance. They have a small nose and a small chin. They also have a wide mouth, and they have a long philtrum, which is the length of the upper lip. These children have These children have intellectual ability, and they often show delayed developmental milestones. However, interestingly, they have very well-developed verbal skills and have a unique personality where they're extremely friendly with strangers. They're unafraid of strangers, and they have great interest in talking with adults, which is unusual for many children. There are some unusual and uncommon vascular manifestations of Williams syndrome, and if you know these, it's very easy to recognize Williams syndrome in a board question. The first one is called supravalvular aortic stenosis. This is a constriction of the ascending aorta just above the aortic valve. So it behaves like aortic stenosis, but it's caused by a constriction of the aorta above the valve. That's why it's called supravalvular. And there's a very high prevalence among children who have Williams syndrome. In addition, these children can also develop pulmonary artery stenosis and renal artery stenosis. So they are developing narrowings of large arteries in the vascular system. This is very unusual, and if you see these things described in a child, they are probably talking about Williams syndrome. These children also can develop hypercalcemia. In general, they have higher calcium than the pediatric population. There's evidence of increased vitamin D levels and increased sensitivity to vitamin D among children with Williams syndrome. It's usually not severe. It's usually mild to moderate. It usually does not cause symptoms. However, it is thought that it may contribute to constipation, which is common in children with Williams syndrome. The last deletion syndrome I'll discuss is thymic aplasia or DeGeorge syndrome. I discussed this disorder in detail in the immunology section in the video on immune deficiency syndromes. And the reason I talk about it there is because one of the key features of this disorder is immune deficiency. This disorder goes by many different names that can be confusing as a student. It's sometimes simply called a 22q11 deletion syndrome, and that's because it results from a partial deletion of the long arm of chromosome 22. It's also sometimes referred to as velocardiofacial syndrome or Spritzen syndrome or conotruncal anomaly of the face syndrome. And the reason it has all these different names is because the clinical presentation is widely varied, but some of the key features include immune deficiency, hypocalcemia, and congenital heart defects. And that concludes our video on deletion syndromes. Hi, everybody, and welcome to our module on Klinefelter and Turner syndromes. Klinefelter and Turner syndrome are sex chromosome aneuploidy disorders. This means these are genetic disorders where the affected individual has an abnormal number of sex chromosomes. Klinefelter syndrome occurs in males who have an extra X chromosome. For example, they may be XXY when they should be simply XY. Turner syndrome occurs in females who are missing an X chromosome, so instead of being XX, they are referred to as X0, meaning they only have a single X chromosome. Both of these disorders can be diagnosed by sending a patient for a test known as a karyotype. A karyotype involves counting the number of chromosomes. This is a picture of a karyogram shown on the screen here. And in patients who have Klinefelter or Turner syndrome, you will either see an extra copy of the sex chromosomes or only a single copy of the X chromosomes. And often multiple cells are analyzed for the numbers of chromosomes because, as we will see, some patients with these disorders display mosaicism, meaning not all of the cells in their body have abnormal numbers of sex chromosomes. Let's start by talking about Klinefelter syndrome. In 80% of cases, Klinefelter syndrome occurs in boys who are 47XXY. This means they have 47 chromosomes instead of the usual 46. They have X and Y just like normal boys should, but then they have an extra X chromosome. And this is usually the result of meiotic non-disjunction of either parent. I talk about how this occurs in the video on meiosis. Rarely, these boys are 48XXY, meaning they have two extra X chromosomes. These tend to be more severe cases because they have another X chromosome in addition to the one extra that most cases of Klinefelter syndrome have. And then sometimes boys with Klinefelter syndrome display what's known as mosaicism, which I talk about in other videos. In mosaicism, some cells in the body have different numbers of chromosomes compared with others. In this case, some cells in the body are normal. In other words, they are 46XY with just one X and one Y chromosome, whereas other cells are 47XXY and are abnormal. These tend to be less severe cases because some cells in the body have the normal complement of sex chromosomes. And these cases of mosaicism are not due to meiosis errors. They're usually due to mitosis errors. They occur due to non-disjunction during mitosis after conception. And the same thing is true in other genetic disorders where there is mosaicism. This can occur in Down syndrome, where mosaicism is due to mitosis errors and not meiotic errors. This is a karyogram of a patient with Klinefelter syndrome. You can see that there are two copies of all the numbered chromosomes, and then there are also two copies of the X chromosome and one copy of the Y chromosome. Thus, this patient has 47 chromosomes and 3 sex chromosomes with an extra X. An easy way to remember the features of Klinefelter syndrome is to think of it as a feminized male. The patients who have this disorder have an X and Y chromosome, so they are male in appearance. However, because of the extra X chromosome, they have many female features. So one of these features is that they are going to display hypogonadism. Their testes are going to be underactive because of that extra X chromosome. They have small, firm testes. They have atrophy of the seminiferous tubules. They typically have low testosterone levels, and we'll talk more about this in a minute. And it is the ratio of estrogens to testosterones that determines the disease severity. Individuals that have 2 extra X chromosomes have lots of estrogens relative to testosterone, and they have more severity of their disorder. Because the testes are hypoactive, the levels of gonadotropins coming from the pituitary gland will increase. So there will be low levels of inhibin B coming from the testes. This will lead to high levels of FSH from the pituitary. There will be low testosterone from the testes. This will lead to high levels of LH coming from the pituitary. Here's a slide from our endocrinology video on male reproductive hormones, just to remind you that in the testes, you can find Leydig cells and Sertoli cells, and they make testosterone and inhibin, which feed back negatively on the pituitary gland. So in Klinefelter syndrome, when you have lower levels of testosterone and lower levels of inhibin because the testes are underactive, this leads to loss of negative feedback, and thus the levels of LH and FSH can rise. Low testosterone and relative excess of estrogen account for many of the clinical features of Klinefelter syndrome. Boys with this disorder display delayed puberty, and in fact, this disorder is often first diagnosed at puberty because prior to that point, the children will appear to be a normal male. These boys have reduced facial and body hair. They often have a female pubic hair pattern, as is shown in this picture on the screen here. They can develop gynecomastia, and in addition, they often have infertility and reduced sperm counts. Genital anomalies are common in boys with Klinefelter syndrome. First of all, they often have cryptorchidism, which is undescended testes. In addition, they often have hypospadia. Hypospadia is where the opening of the urethra is not in the normal position at the head of the penis. Shown on the screen are a couple examples of different types of hypospadia. And then finally, boys with Klinefelter syndrome often have a very small penis. This is called micropenis. Patients with Klinefelter syndrome have a characteristic physical appearance. First of all, they usually have long legs and arms. This is because they have an extra copy of the SHOX gene, which is found on the X chromosome, and this gene is important for long bone growth. Shown on the screen is a picture of a man with Klinefelter syndrome. You can see that he's tall and has relatively long arms. In addition, they are usually described as having a unicoid body shape. A eunuch is an asexual individual, so when people say they have a unicoid body shape, what they mean is that they are male, but they lack the typical male features like broad shoulders and muscular arms. Patients with Klinefelter syndrome can display cognitive findings. They sometimes have learning disabilities like delayed speech and language development. They also often have a quiet personality, meaning that they are relatively quiet individuals and not very assertive. For the USMLE Step 1 exam, it's high yield to know that patients with Klinefelter syndrome can have a Barr body found in the nucleus of their cells. A Barr body is an inactivated X chromosome. It's normally found only in the cells of females. Females are XX. So one of their X chromosomes undergoes a process called lyonization, where that X chromosome becomes condensed into heterochromatin with methylated DNA, and thus it becomes inactive, so that in each cell of a female's body, only one X chromosome is active, the other one is inactive and appears as a Barr body, which I've shown on the screen here. It's a dark spot at the periphery of the nucleus, and it indicates an inactive X chromosome. In patients with Klinefelter syndrome, you can also see a Barr body, and normally you do not see this in males, but you will see it in males who have Klinefelter syndrome because they have that extra X chromosome. In contrast to Klinefelter syndrome, in Turner syndrome, there is a missing sex chromosome. 45% of cases occur in girls who are 45X0. This means they have 45 chromosomes instead of the usual 46, and they only have a single sex chromosome, an X chromosome. They are missing the second copy of their X chromosome. Most of these cases are caused by fertilization of an egg with a sperm that lacks the X chromosome. Many cases of Turner syndrome are what's known as mosaic Turner syndrome. These are often milder cases. In these cases, girls are born with a mosaic of chromosomes in their body. So some cells will be 45X, but other cells will be normal and will be 46XX. This version of Turner syndrome, mosaic Turner syndrome, is caused by mitotic non-disjunction during the postzygotic cell division stage. And this is common to many genetic disorders. Mosaic Down syndrome is caused by mitotic non-disjunction. Mosaic Klinefelter syndrome is caused by mitotic non-disjunction. And so is mosaic Turner syndrome. We saw before that Klinefelter syndrome is a male who is very tall. In contrast, Turner syndrome will be a female who is very short. And this is because girls with Turner syndrome have lost one copy of that SHOX gene on the X chromosome we mentioned earlier. And because females with Turner syndrome are often short, they are often administered growth hormone in childhood to try to have them develop to a normal height. Other classic features of Turner syndrome include a broad chest. This is sometimes described as a shield chest because the chest looks sort of square like a shield would in medieval times. And in addition, they often have widely spaced nipples. So they'll have the shield chest with the nipples very far apart on the chest. There are a couple of features of Turner syndrome that are believed to result from lymphatic obstruction that occurs during fetal development. Girls with Turner syndrome classically have a webbed neck, as shown in this picture on the right side of the screen. This is believed to result from poor lymphatic flow during fetal development. In addition, babies with Turner syndrome often have swollen hands and feet, especially right at the time of birth. Some girls with Turner syndrome have an anomaly called a cystic hygroma. This is a congenital lymphatic defect. There's a picture of one shown in this child on the screen here. It's a large collection of lymph and cysts. That's why it's called a cystic hygroma. It's often found in the head and neck, and it is sometimes detected in utero on fetal ultrasound. Ovarian function is typically abnormal in girls with Turner syndrome. The hallmark of the disorder is a female with primary hypogonadism. These girls have loss of ovarian function. It's often described as gonadal dysgenesis. In addition, a classic finding is what's known as streak ovaries. This is where there are streaks of fibrous tissue seen in the expected location of the ovaries, and these girls have no or very few follicles. Shown on the screen is a picture of the ovary. It's normally found in the middle of the broad ligament, but in girls with Turner syndrome, instead of ovarian tissue, there will be streaks of fibrous tissue, hence the name streak ovaries. Because the ovaries are abnormal, there are decreased levels of inhibin B and estrogens to feed back on the pituitary gland, and therefore you can see increased levels of LH and FSH, just like we talked about in Klinefelter syndrome. In actual practice, it turns out that the levels of LH and FSH vary during childhood. They are sometimes normal during certain periods of development. Therefore, you can't rely on these for diagnosis. They're often most abnormal in early childhood and pre-puberty after 10 years of age. If this disorder isn't picked up early because of presence of a webbed neck or puffy feet or cystic hygroma, it's often diagnosed at the time of puberty. Girls with Turner syndrome will display delayed puberty. They will have absence of breast development and failure to menstruate. This is sometimes treated with estrogen supplementation to try and induce normal changes of puberty in girls who have this disorder. In addition, Turner syndrome typically leads to primary amenorrhea. In fact, it is the most common cause. This is sometimes referred to in textbooks as menopause before menarche. Basically, these girls are born with insufficient ovarian tissue, so they have menopause before they've had the start of menses. Now, some girls will menstruate and develop menopause early in their teens or 20s. These are usually girls with the milder form, the mosaic form of Turner syndrome. Most women with Turner syndrome are infertile. As I mentioned before, they are born with zero or relatively few ovarian follicles. Some women can become pregnant if they use donated oocytes because they can carry the baby to term once the egg has been fertilized. It's very high yield for step one to know the cardiovascular complications of Turner syndrome, which I've listed on this slide. About a third of girls born with Turner syndrome have a bicuspid aortic valve. Normally, the aortic valve has 3 cusps, but in about 30% of girls with Turner syndrome, it has 2 cusps, as shown in this picture on the screen. Up to 10% of girls with Turner syndrome have coarctation of the aorta, as shown in this picture here. I discussed this in detail in the cardiology section in the video on congenital heart defects. And then finally, high blood pressure is common in girls with Turner syndrome and may even occur in childhood. It is sometimes due to the coarctation of the aorta or renal disease, which we'll talk about in a minute. However, it's often a primary disorder. Kidney malformations affect about a third of children with Turner syndrome. Often it is an abnormality of the collecting ducts. However, children with Turner syndrome can also develop a horseshoe kidney, which is something they like to test on step one of the boards. This is a horseshoe kidney shown on the screen here. The lower poles of both kidneys are fused, and for this reason, the fused horseshoe kidney sits lower in the pelvis. I talk about horseshoe kidney in the renal section in the video on embryology. There's a high incidence of osteoporosis in women with Turner syndrome. This is because there are low levels of circulating estrogens because of the single X chromosome. And for this reason, estrogen treatments are often prescribed in order to increase the bone density. And then finally, women with Turner syndrome often have endocrine disorders. Type 2 diabetes is more common than in the general population, and about a third of women with Turner syndrome have some form of thyroid disease. It's usually hypothyroidism from Hashimoto's thyroiditis. And that concludes our video on Klinefelter and Turner syndromes. Hello, everyone, and welcome to our module on cellular adaptations. The cells in our body are often exposed to a stressor. A stressor could be something pathologic like ischemia, or maybe heat, or maybe an infection, or a stressor could be something physiologic. For example, when a woman becomes pregnant, the baby begins to grow and that changes hemodynamics, that adds a new structure in the abdomen. So that's another example of a stressor, although it's not a disease state. When cells are exposed to these stressors, they can adapt. This is that they undergo a reversible change in response to stress. The cell will try to change itself to give it a better chance at survival in an environment with that stressor. Now, there's only a limited ability of cells to adapt, so if the stressor is too great, eventually the cell will become injured. And in another video, I talk about reversible and irreversible forms of cellular injury. And then finally, cells can die if a stressor is too strong or overwhelms the ability of the cell to adapt. We're going to talk about the four main types of cellular adaptations in this video. The first one is hypertrophy. That's an increase in the size of the cell. The second adaptation is hyperplasia. That's an increase in the number of cells in a tissue bed. And this often occurs together with hypertrophy. Many stressors lead to both hyperplasia and hypertrophy. We'll also talk about atrophy, which is a decrease in cell size. And finally, we'll talk about metaplasia, which is a change in the phenotype of a tissue bed. Let's start with hypertrophy. This is an increase in cell size. Cells that undergo hypertrophy synthesize more proteins, more filaments, and they become larger. This often occurs together with hyperplasia, as I said before, but you should be aware that muscle tissues like your heart and the muscles in your arms undergo only hypertrophy. They do not undergo hyperplasia. What this means is when you lift lots of weights, for example, like this man shown on the screen here, you will not increase the number of muscle cells, but the muscle cells you have will get larger. The same is true in the muscle tissue of the heart. When the heart is exposed to increased afterload, it will undergo hypertrophy. In other words, more sarcomeres will be laid down in the cardiac myocytes, but the cardiac myocytes will not divide and increase in number. In other words, they will not undergo hyperplasia. So there are a number of physiologic examples of stressors that lead to hypertrophy. Bodybuilders, like I showed you on the last slide, undergo muscle hypertrophy. The uterus undergoes hypertrophy in pregnancy. This is driven by the hormones of the pregnant state. And then the classic pathologic example of hypertrophy is a cardiology example, left ventricular hypertrophy. So this is a drawing on the screen of a left ventricle that has very thick walls. This is an example of concentric hypertrophy. And this occurs in the left ventricle when people have hypertension or there's an increased workload on the heart. The next cellular adaptation is hyperplasia, which, as I told you before, is an increase in the number of cells in the tissue bed. This occurs in many situations when there's excess hormone stimulation. This is the classic response to hormone stimulation. It can be physiologic or pathologic, and as I told you before, in many cases it is accompanied by hypertrophy, such that cells in a tissue bed exposed to a stress not only increase in number, that's hyperplasia, but they increase in size, that's hypertrophy. Shown on this slide are some physiologic examples of hyperplasia. Breast growth in girls at puberty is due to hyperplasia and hypertrophy of glandular epithelial cells and breast tissue. Your liver, you may know, is capable of regeneration. Some people donate part of their liver to another person. When they do this, the liver grows back to full size, and that's because the remaining hepatocytes undergo hyperplasia. And then finally, your bone marrow is capable of hyperplasia. When there is anemia, there will be hyperplasia of red blood cell precursors, and this can increase the production of red cells. In fact, your bone marrow can increase production by up to 8 times normal if it needs to, and that's due to hyperplasia of red cell precursors. Shown on this slide are some pathologic examples of hyperplasia. One of the classic examples is endometrial hyperplasia, which I talk about in detail in videos in the reproductive section. This is a hormone-driven process. As I told you, hyperplasia often occurs in response to hormone stimulation. In this case, the endometrial lining is growing due to estrogen stimulation. The prostate gland can also undergo hyperplasia. This is also a hormone-driven response. In this case, it's an adaptation to the stressor of excessive response to androgens. And I also talk about this in the reproductive section. And then finally, human papillomavirus can infect your skin or your genitals and cause hyperplasia. It gets into the cell and stimulates cell division. If it gets into the skin, it can cause skin warts, like is shown here. This is due to hyperplasia of the epidermis. If it gets into the genital mucosa, it can cause mucosal hyperplasia, and that leads to genital warts. One of the basic principles of pathology is that anytime you have cells that are rapidly dividing, this can lead to malignancy, and this includes in the setting of hyperplasia. The reason for this is that anytime cells are dividing, they are copying their DNA. And every time they copy their DNA, there's a small chance of an error. If that error leads to a genetic mutation, that gives the cell immortality and allows for uncontrolled cell growth that can lead to malignancy. So that means that in settings where cells are rapidly dividing, including hyperplasia, there is increased cell division. There's more chances for an error in copying DNA that leads to errors in cell cycle control. And this can lead to uncontrolled growth, such as in this patient whose liver is full of tumors here. That person has developed malignancy, which can come from hyperplasia. Earlier, I mentioned that the prostate gland can undergo hyperplasia in response to androgens. This is a pathologic example of hyperplasia. But I want to point out that this is a unique form of hyperplasia in that it is benign and does not lead to malignancy. That's why it's referred to as BPH, or benign prostatic hyperplasia. This is very unusual in that hyperplasia of the prostate gland is not associated with an increased risk for malignancy. The reasons for this are not completely understood. Let's talk about why some cells undergo hypertrophy versus hyperplasia. Certain cells are called permanent or non-dividing cells. The major cells in this category are heart cells like myocytes and skeletal muscle cells and nerves. These cells are in a permanent G0 state of the cell cycle. They're called terminally differentiated. These cells rarely ever divide, and therefore the main response to stress that you see is hypertrophy, especially in the heart and in muscle. Other cells are capable of growth and division even under normal circumstances. For example, epithelial cells have stem cells within the epithelial cell layer that can regenerate lost epithelial cells. You find this in the GI tract, the breast ducts, and the skin. So these cells are normally capable of division, and therefore when faced with a stress, they commonly undergo hyperplasia. And this in many cases leads to dysplasia and cancer. So for this reason, you hardly ever see cancers in the heart or in skeletal muscle, but you commonly see cancers in the GI tract, the breast ducts, and the skin. And that's because these places have cells that are capable of cell division. Those cells often undergo hyperplasia, and as I told you before, hyperplasia can lead to malignancy. Our next cellular adaptation is atrophy. This is a reduction in size of an organ or tissue. It can be due to both a decrease in the size of the cells in that organ or a decrease in the number of cells. There are a bunch of physiologic examples of this. Many embryonic structures in utero, for example, the notochord, do not persist into adulthood. And the reason they don't persist is because they undergo atrophy as the fetus is developing. After childbirth, the uterus is going to shrink, and that's because it loses hormone stimulation. So the uterus, therefore, is going to undergo atrophy, and you're going to see a decrease in both the number of cells in the uterus and the size of the cells. And then at menopause, there's a fall in hormone levels in women, and this can lead to shrinking of the breast and uterus, and that is another example of physiologic atrophy. Some pathologic examples of atrophy include unused skeletal muscle. You may know if you don't go to the gym for a while, when you usually do go to the gym often, that your muscles will shrink. That's atrophy. This can be pathologic when patients are on prolonged bed rest or if they have muscle tissue that's immobilized, for example, if they have to wear a cast after a fracture. This can lead to atrophy. And this is a big problem in elderly patients who are hospitalized for a long period of time. When they get out of the hospital, they are often deconditioned and have a lot of trouble doing their daily activities. That's because they've had skeletal muscle atrophy from prolonged bed rest. Cachexia is a form of wasting in the setting of poor nutrition. This is a child from a country that has famine and starvation, and all of his organs and his muscle tissue are undergoing atrophy because of poor nutrition. If there's decreased blood supply to an organ, it can atrophy. One example of this is senile atrophy of the brain. The brains of elderly people are smaller than the brains of younger people. There are many reasons for this, but one of them is believed to be that atherosclerosis leads to decreased blood flow, and that contributes to senile atrophy. And then finally, if there's loss of innervation to a muscle, as occurs in neuromuscular disorders, this can lead to atrophy. This is a big problem for many people with neuromuscular disorders. First of all, they're not using their muscles, and that leads to atrophy, but it's not just that. If the muscle is not properly innervated, it also undergoes atrophy. So let's think about a skeletal muscle cell that's not being used and undergoes atrophy. What is happening on a cellular level that makes that muscle cell shrink? Well, the first thing that's happening is the ubiquitin proteasome pathway is being activated. I talk about this in some of the videos in the cell biology section, but by way of review, ubiquitin is a substance that can be tagged to proteins. And when ubiquitin is attached to a protein, it is transported to the proteasomes and the protein gets degraded. And there are many stressors that have been shown to activate enzymes called ligases that attach ubiquitin to a protein, and this leads to protein breakdown. A second cellular mechanism of atrophy is called autophagy, which means self-eating. Cells have been shown, when exposed to certain stressors, to fuse components of the cell with lysosomes, so they are broken down. It's high yield to remember that these are two of the well-described mechanisms by which cells undergo atrophy. Our next adaptation is metaplasia. This is a change in cell type to adapt to stress. If cells are exposed to stress, in some situations, they will change their shape. They will change what they look like, and the new cell type is better able to withstand the stress. This is very common among epithelial cells where they change from one type to another. For example, a squamous epithelial cell becomes a columnar or vice versa. It's potentially reversible. If the stressor is removed, the cell can go back to its original form. However, if the metaplasia persists, this can lead to dysplasia, which we'll talk about in a minute, and malignancy. So just like hyperplasia is often a precursor of malignancy, metaplasia is also commonly a precursor. In metaplasia, you have cells changing their shape. They also are dividing, and there's increased risk for a mutation that leads to uncontrolled growth. So let's go through some clinical examples of metaplasia. A classic one is the respiratory tract in smokers. Normally, your respiratory tract is made up of columnar epithelium, which you find in the trachea and bronchi. But if this epithelium is exposed to smoke, it will change into a squamous epithelium. This is the most common form of metaplasia, is transformation from columnar to squamous cell epithelium. This occurs in many cases, including when your respiratory tract is exposed to smoke. And the reason this is the most common type of metaplasia is because squamous epithelium is much more durable than columnar epithelium. The problem for smokers is that the squamous epithelium does not have cilia, so now they are more vulnerable to infections, and this is one of the many reasons that smoking is bad. In addition, you may know that many smokers develop squamous cell carcinoma, and that's because their respiratory tract has transformed due to metaplasia. And this is a picture on the bottom to help you remember. This is what the respiratory tract should look like, but it starts to look like this when it is exposed to cigarette smoke. Another classic example of metaplasia is Barrett's esophagus, which I talk about in detail in videos in the GI section. When gastric acid gets into the esophagus, it is a stressor, and it transforms the normal esophageal mucosa, which is stratified squamous epithelium, into columnar epithelium, similar to the epithelium of the intestines. This is an example of it on the screen here. On the right side of the screen is what the esophageal mucosa should look like, and on the left side of the screen is what it's transforming into. And I talk about this in great detail in the GI section. Another example of metaplasia is myositis ossificans. It's also referred to as heterotopic ossification. In this form of metaplasia, muscle tissue turns into bone, and this is an important example of metaplasia because it does not involve epithelial cells, and that makes it relatively unusual. Muscle and bone are both examples of mesenchymal cells, and in this situation, one type of cell, muscles, turns into another bone and forms osteoblastic tissue, and this tissue will lay down lamellar bone inside of muscles. This classically occurs following trauma, for example, hip arthroplasty. The muscle around the joint that is repaired and undergoes surgery will become stiff, and this can lead to problems for the patient. And shown on the screen is an x-ray from a person who has had surgery. You can see the screw, and the muscle tissue here has white puffy clouds in it. That is an example of myositis ossificans. Another clinical example of metaplasia is vitamin A deficiency. Vitamin A is very important for maintaining epithelial cells, and as we just discussed, epithelial cells are the type of cells that most commonly undergo metaplasia. In the vitamin A deficient state, epithelial metaplasia can occur and keratinization of the epithelium can occur. This means increased content of keratin and thickening of the epithelial layer. In the upper respiratory tract in vitamin A deficiency, you can see epithelial metaplasia where the normal epithelium is replaced by keratinizing squamous cells. This will lead to an abnormal epithelium that has difficulty clearing secretions and resisting bacteria, and that can lead to recurrent pulmonary infections. In the eyes, patients who are vitamin A deficient often develop xerophthalmia, which means dry eyes. This is because the normal epithelium in the eyes secretes mucus, but when that epithelium is replaced because of metaplasia to keratinized epithelial cells, they don't make normal mucus, and therefore the eyes become dry. And then a final example of metaplasia is apocrine metaplasia. I talk about this in the breast videos in the reproductive section. This is a form of fibrocystic breast change. It's also called benign epithelial alteration because it is a benign condition that does not lead to breast cancer. In this form of metaplasia, there are alterations to the normal lobular epithelial cells, and they begin to look like apocrine or glandular cells. Basically, they begin to look like sweat glands. They develop an enlarged appearance with eosinophilic staining, and this is called apocrine metaplasia. And just like I told you before, that prosthetic hyperplasia is special in that it's a form of keratinized epithelial cells. They don't make normal mucus, and therefore the eyes become dry. And then a final example of metaplasia is apocrine metaplasia. I talk about this in the breast videos in the reproductive section. This is a form of fibrocystic breast change. It's also called benign epithelial alteration because it is a benign condition that does not lead to breast cancer. In this form of metaplasia, there are alterations to the normal lobular epithelial cells, and they begin to look like apocrine or glandular cells. Basically, they begin to look like sweat glands. They develop an enlarged appearance with eosinophilic staining, and this is called apocrine metaplasia. And just like I told you before, that prostatic hyperplasia is special in that it's a form of hyperplasia that does not lead to malignancy. Apocrine metaplasia is also special in that it is a form of metaplasia that does not lead to dysplasia and cancer. Most forms of metaplasia, just like most forms of hyperplasia, are associated with an increased risk for malignancy. Apocrine metaplasia is unique, and the reasons for this are not well understood. I'll finish by talking about dysplasia, which is disordered cellular proliferation. So this is cell growth, just like hyperplasia or metaplasia, but it's disordered. In hyperplasia, cells increase in number, but they maintain the normal cellular architecture. In metaplasia, cells shift from one type to another, but again, they maintain the normal tissue architecture. In dysplasia, the cells are disorderly and they lose the normal tissue architecture. This is a non-neoplastic condition, but it can be precancerous. Patients who have mild dysplasia of a particular tissue may see that dysplasia resolve if the stressor is removed. In contrast, severe dysplasia is often irreversible and leads to cancer. This usually occurs in epithelial cells. It's classically described in epithelial cell layers, and it's usually preceded by hyperplasia or metaplasia. So there's a normal cell, as shown at the bottom of the screen. There's some stressor. The cell develops hyperplasia or metaplasia, but if the stressor persists, eventually these transform into dysplasia, which means the patient is getting closer and closer to having cancer. You won't be asked to identify dysplasia under the microscope. This is something pathologists do a 3-year residency to learn how to do. One of the most important things pathologists do is identify and grade dysplasia on biopsies, but you should be familiar with some of the cellular changes that indicate dysplasia. The first one is pleomorphism. So cells and their nuclei display lots of variability in size and shape when there is dysplasia present. A second change is abnormal nuclei. The nuclei can become very dark, that's hyperchromatic, and they can also enlarge when cells are undergoing dysplasia. And then finally, tissue beds that have dysplasia occurring will demonstrate lots of mitotic figures, which are clumps of chromatin. These are evidence that mitosis is occurring. If you look at the bottom left side of the screen, you can see a dark nucleus that is clumped. That is evidence of a mitotic figure. On the right side of the screen, you can see chromatin that is separating in metaphase. That is also evidence of a mitotic figure. Under normal circumstances, you may see rare mitotic figures, but when you see lots of mitotic figures, that indicates lots of cellular division, and that is evidence of dysplasia. And the classic clinical example of dysplasia is in the cervix. In cervical dysplasia, the normal cervical epithelial layer, which is shown on the left, transforms into dysplastic tissue. Note that the normal layer is nice and orderly with layers of cells. On the right, what you see is that normal architecture has been completely obliterated. The nuclei of the cells show lots of change in shape and darkness. That is evidence of dysplasia. And that concludes our video on cellular adaptations. Hello, everyone, and welcome to our module on cellular injury. Broadly speaking, there are 4 general mechanisms by which cells can become injured. The first one is if the capacity for adaptation is exceeded. In another video, I talk about cellular adaptation and how cells adapt to accommodate stressors in the environment. But that adaptation has a limit, and if that limit is exceeded, the cell can become injured. Another way cells are injured is by exposure to certain agents that are toxic or injurious. Cells can become injured if they're deprived of nutrients, and they can also become injured if there is a genetic mutation that leads to disruption of cellular metabolism. So all this is fairly obvious, but I just want to point out that these are the general ways by which cells are injured. Now, cellular injury is usually reversible up to a point, but if the cause of the injury is severe or if it persists, the injury may become irreversible, and at that point, this can lead to cell death. There are 2 general ways by which cells die. The first way is called necrosis. In necrosis, a cell essentially falls apart and spills its contents, which triggers inflammation, and the inflammation itself can damage more cells. Necrosis almost never happens to one cell all by itself. It usually happens to sheets of cells or tissue beds that are all connected together. The second way that cells die is called apoptosis. This is also called programmed cell death. This is a way by which an individual cell basically kills itself in an orderly manner so that it dies and does not cause harm to the body. This is a non-inflammatory process, and I talk about apoptosis in another video all by itself. What we're going to focus on here is the fact that when cells undergo death by necrosis, the cell death is preceded by classic cellular changes, and you need to know these for step one. These changes happen to any cell in the body that's going to undergo cell death by necrosis. For example, myocardial cells after infarction or pancreatic cells in the setting of pancreatitis. These cells will go through some reversible changes of cell injury, and then if the stressor persists, the changes will become irreversible and the cell will progress to go through necrosis. First, let's talk about what happens to cells when they undergo reversible cell injury. So, for example, when myocardial cells are deprived of oxygen due to ischemia, initially they undergo reversible cell injury. If the ischemia persists or it's severe, then the cell will progress to die by necrosis, and we'll talk about what those changes look like later. But first, let's talk about the changes of reversible cell injury. And one of the hallmarks of reversible cell injury is that the cell will swell. This is a major feature of most forms of reversible injury. It is sometimes called hydropic change, which means water accumulation inside the cell. This is very difficult to see under the microscope. It's unlikely you'll be asked to recognize it on your exam. You just need to know that this occurs as part of reversible cell injury. And the reason it occurs is because when cells are injured, there's less activity of sodium-potassium ATPase pumps. Let's look at my drawing I've placed on the screen here. In many cells in our body, you find sodium-potassium pumps that are driven by ATP. So ATP is used to bring potassium into the cell and pump sodium out of the cell. If these pumps become less active due to injury, what will happen is more sodium will stay inside the cell. That sodium will draw in water, and hence you will get cellular swelling. In addition, sodium is often exchanged for calcium through a sodium-calcium exchanger. So when there's more sodium inside the cell, there's less exchange via this pump, and that leads to more calcium inside the cell. So the bottom line here is that during injury, when there's less activity of this pump, you end up with more sodium and calcium inside the cell, and that leads to swelling of the cell, one of the hallmarks of reversible cell injury. Another form of reversible cell injury is called fatty change. This is seen only in parts of the body that heavily metabolize fatty acids. So, for example, you can see fatty change in the liver. You can also see it in muscle tissues like the heart and skeletal muscle. And in contrast to cellular swelling, this is very easy to recognize under the microscope, and you should know what it looks like. The cells develop lipid vacuoles in the cytoplasm, and this is a picture on the screen of a liver that's undergone fatty change. This is another example of reversible cell injury. If the cause of cell injury is withdrawn, the fatty change can go away and the liver cells can go back to appearing normal. Some other features of reversible cell injury are shown on this slide. First of all, the mitochondria inside of cells can swell. Remember, mitochondria are sort of like their own little cell inside another cell. So just like the cell itself can undergo injury, the mitochondria inside the cell can undergo injury. Membrane blebbing is another hallmark of reversible cell injury. This is a drawing of it on the screen. Basically, what happens is there's a cytoskeleton inside the cell that maintains the cell in its normal shape, for example, circular. When that cytoskeleton is injured, then the cell loses its shape and pieces of the membrane start to form blebs. And then finally, you should know that cells that undergo reversible injury have dilation and enlargement of the endoplasmic reticulum. This is where proteins are synthesized inside the cells. And when there is cellular injury, ribosomes detach from the endoplasmic reticulum and there's less protein synthesis. You will read in your textbooks that reversible cell injury involves polysomal detachment from the endoplasmic reticulum. A polysome is a cluster of ribosomes. So what's in the endoplasmic reticulum? This is where brains start to form blebs. And then finally, you should know that cells that undergo reversible injury have dilation and enlargement of the endoplasmic reticulum. This is where proteins are synthesized inside the cells. And when there is cellular injury, ribosomes detach from the endoplasmic reticulum and there is less protein synthesis. You will read in your textbooks that reversible cell injury involves polysomal detachment from the endoplasmic reticulum. A polysome is a cluster of ribosomes. So what they're describing is this process of dysfunction of the endoplasmic reticulum. Another class feature of reversible cell injury. So now that we've talked about the changes you see in cells that undergo reversible cell injury, let's talk about the changes you see in cells that develop irreversible cell injury. These are cells that have progressed through reversible changes and are going to undergo necrosis. So once again, let's go back to our example of the heart when it suffers from ischemia. Initially, the myocytes may go through reversible changes, but if the ischemia persists, the cell is then going to enter the necrotic phase and undergo irreversible cell injury. So let's talk about what that looks like. Well, first of all, in irreversible cell injury, the membrane becomes damaged and the contents leak out, and this causes inflammation. And that's why necrosis is the form of cell death that is associated with inflammation. This is also very important clinically because when contents of cells spill out, you can detect them in the serum. And this is why we can measure the troponin level in patients with myocardial infarction or the lipase level in patients who have pancreatitis. Cells are undergoing necrosis and irreversible injury, and these things are spilling out into the serum. Another thing that happens when membrane damage occurs as part of irreversible cell injury is that enzymes called calcium-dependent phospholipases become active, and they further damage the cell. I'm going to talk more about this in just a couple of slides. Another feature of irreversible cell injury is that the lysosomes inside the cell rupture and they spill their contents. And as you know, lysosomes contain enzymes that break down other substances in the cell, so this leads to more cell damage. There are three classic nuclear changes that you can see in the nucleus of a cell when it undergoes irreversible cell injury. The first is called karyolysis. This is loss of the basophilic or dark color of the nucleus. This is a drawing of it on the screen here. These changes are very hard to see under the microscope, and it's unlikely they'll show them to you in an actual tissue sample on the board. You just need to know what they are. The second change is called pycnosis. This is nuclear shrinkage. This is also a picture of it on the screen here. And then finally, karyohexis is a fragmented nucleus. Basically, the nucleus falls apart, and then you see something that looks like this on the right side of the screen. Okay, so now we've talked about the changes you can see in cells when they undergo reversible injury. We've also talked about the changes you can see in cells undergoing irreversible injury or necrosis. What I'm going to finish this video with is a discussion of the mechanisms by which cells get injured and undergo those reversible and irreversible changes. And there are basically four mechanisms by which cells are injured to lead to all these changes. The first one is ATP depletion. The second one is calcium. The third one is mitochondrial damage. And the final one is free radicals, which I'm going to talk about in a separate video all by itself. So ATP depletion causes many of the changes seen in cells. There are many reasons that a cell can be deprived of ATP. If the oxygen supply is cut off to a cell, this can lead to ATP depletion. This happens in the heart when there is ischemia. Mitochondria can become damaged, and when mitochondria are damaged, then the mitochondria cannot produce ATP. And then finally, there are some toxins that directly affect the production of ATP inside of cells. When ATP becomes depleted, the cell can't maintain its membrane pumps like we talked about earlier, and the cell can't synthesize proteins, and this leads to reversible and irreversible changes. It's high yield to know that calcium inside of cells is very bad, and when calcium gets inside of cells, this leads to cell injury. Normally, the calcium level is very low compared with outside the cell. So an influx of calcium is one of the hallmarks of cellular injury. Very high yield to remember this. There are a couple of reasons that calcium levels inside of cells can go up when they're subjected to a stressor. Calcium can be released from intracellular storage. It can also influx across the cell membrane when the membrane becomes damaged. Calcium causes cellular injury through a couple of mechanisms. One of the main ones to know about is what I mentioned before. There are enzymes inside of cells called calcium-dependent phospholipases. These enzymes are activated by increased calcium, and they break down membrane phospholipids. That's why they're called phospholipases. So anytime calcium gets inside of cells, it will activate these enzymes and the cell will basically begin chewing itself up. In addition, calcium inside of cells can also damage the mitochondria, which can further lead to cellular injury. Our final mechanism of cellular injury for this video is mitochondrial damage. So how can mitochondria inside of cells become damaged? Well, first of all, mitochondria need oxygen and energy to function just like the cell itself needs oxygen and energy. So if there isn't enough oxygen, the mitochondria won't be able to generate ATP and won't be able to maintain its membrane and structural proteins. Reactive oxygen species are a type of free radical, which I talk about in another video, and they can damage mitochondria. And then finally, mitochondria have something called the mitochondrial permeability transition pore. This is a hole in the mitochondria that is opened by calcium. And as I told you before, calcium influx causes lots of damage to cells. So not only can calcium damage the cell, it can also damage the mitochondria by opening this pore. This will cause the mitochondria to lose its membrane potential, and that will lead to failure of oxidative phosphorylation. And this is a hole in the mitochondria that is opened by calcium. And as I told you before, calcium influx causes lots of damage to cells. So not only can calcium damage the cell, it can also damage the mitochondria by opening this pore. This will cause the mitochondria to lose its membrane potential, and that will lead to failure of oxidative phosphorylation, and that will lead to less ATP for the mitochondria and for the cell itself. And that concludes our video on cellular injury. Hi, everybody, and welcome to our module on free radicals. In the video on cell injury, I talked about 4 mechanisms by which a cell can be injured. And the last one, which is free radicals, is a big topic, so that's what we're going to talk about in this video now. Let's start by going through some vocabulary. A free radical is a molecule that has a single unpaired electron in the outer orbit. Free radicals are highly reactive. They often donate electrons to other substances. And in terms of cellular biology, they can damage many cellular components, including the cell membrane, proteins, and other structures. Reactive oxygen species are free radicals that contain oxygen. And as you know, our bodies use oxygen for energy, and therefore reactive oxygen species are the type of free radicals that are often involved in cell biology. Reactive oxygen species come in several forms. One is called superoxide, the other is hydrogen peroxide, and the final one is the hydroxyl radical. And all of these can be produced inside of cells and potentially cause cellular damage. Normal healthy cells in our body generate free radicals even under normal conditions. However, those free radicals are inactivated, and the result is that the cell maintains a relatively low level of free radicals under normal conditions. There's some generation, there's some inactivation, and at any point in time, only a small amount of free radicals is present inside the cell. There are many pathologic processes, however, that lead to high levels of free radicals inside of cells, and this can lead to cell injury and death. And this is why free radicals are such a basic principle of pathology, because they underlie many different disease processes. Let's talk about some of the ways that free radicals are generated inside our cells under normal conditions. Normal cellular metabolism using oxygen generates small amounts of free radicals. This occurs because oxidative phosphorylation yields small amounts of superoxide. It is quickly converted to hydrogen peroxide, another free radical, by an enzyme called superoxide dismutase. And hydrogen peroxide is more stable and it can cross membranes, and it's ultimately converted to water. So in this method, the normal superoxide ions that are made as part of oxidative phosphorylation are inactivated and converted into water. And this happens as part of normal oxidative phosphorylation. So there's always some of these free radicals inside of cells as this process is ongoing. Free radicals are also generated by radiation. So we're all exposed to radiation to some degree when we are out in the sun. UV light contains some radiation. In addition, if you have an X-ray or a CAT scan, that is also a source of radiation. And the fact that radiation can generate free radicals in damaged cells is useful in treating cancer. The goal of radiation therapy, which is what this woman is receiving in this picture, is to bombard the tumor with radiation and generate free radicals and basically kill tumor cells by free radical poisoning. Now, in addition to radiation, a couple of other mechanisms by which free radicals are generated inside of cells include metabolism of drugs, transition metals, and something called the respiratory burst. And in the next few slides, we'll talk about these three things. The metabolism of drugs in our body is classically divided into three phases. In the first phase, drug molecules are modified. This often happens in the liver. In the second phase, drug molecules are conjugated to other molecules. In the third phase, there can be additional modifications to the drug molecule and ultimately excretion. The cytochrome P450 enzymes are an important set of enzymes for drug metabolism found in the liver. They're found in the smooth endoplasmic reticulum of hepatocytes in the liver, and they participate in phase 1 metabolism, drug modification. And for some drugs, what they do is generate free radicals that are called bioactive intermediates, and this can lead to cellular damage, especially liver damage. So for some drugs, modification through the P450 system generates drug-free radicals. And if these drugs are taken in excess amounts, this can lead to liver toxicity. In the videos on the liver in the GI section, I talk about the liver zones. The hepatocytes between the portal triads in the liver and the drainage from the liver to the hepatic vein are divided into three zones. The periportal zone is closest to the portal triads, and the central lobular zone is the furthest away from the portal triads. It is in zone 3, the central lobular zone, that you find P450 enzymes. And if you know that, then you should know that this is the zone where free radical damage is going to occur when medications are consumed that generate excess free radicals. And here is at the liver zones. The hepatocytes between the portal triads in the liver and the drainage from the liver to the hepatic vein are divided into three zones. The periportal zone is closest to the portal triads, and the central lobular zone is the furthest away from the portal triads. It is in zone 3, the central lobular zone, that you find P450 enzymes. And if you know that, then you should know that this is the zone where free radical damage is going to occur when medications are consumed that generate excess free radicals. And here's a biopsy slide of the liver showing the zones. It's right here, zone 3, that you are going to see the damage when patients take drugs that are metabolized by the P450 system into free radicals. The classic example of a drug that causes free radical damage to the liver is acetaminophen or Tylenol. Tylenol is metabolized into a substance known as NAPQI, or N-acetyl-P-benzoquinone amine. NAPQI is a reactive oxygen species, and it causes free radical damage in the liver. This is shown at the bottom of the screen. This is the structure of acetaminophen over here. It's also called paracetamol. The P450 enzymes metabolize it into NAPQI, which is a free radical, and that can damage cells in the liver. And that's why Tylenol is toxic to the liver if you take too high of a dose. Transition metals are another source of free radicals inside cells in the body, even under normal conditions. Earlier, I talked about how oxidative phosphorylation generates superoxide, which is converted to hydrogen peroxide for inactivation by converting it to water. However, if there are transition metals around, instead of the hydrogen peroxide being inactivated, it can react with the metals. Hydrogen peroxide enters something with metals called the Fenton reaction. This is shown on the screen here for iron and copper, two metals found in our body. They can react with hydrogen peroxide and become oxidized and generate the hydroxyl radical. What this means is if you have lots of iron and copper around, then instead of all your hydrogen peroxide going into water, which is what should happen, it will react with the metals and form hydroxyl radicals, which can cause free radical damage. And this is the mechanism by which people suffer tissue damage when they have hemochromatosis or Wilson's. I talk about these disorders in the GI section, but they both involve excess amounts of either iron or copper. And the way they cause toxicity is that instead of the hydrogen peroxide getting inactivated, it reacts with the metals and forms more free radicals. And because of the possibility that transition metals can form free radicals, which can damage cells, our body has evolved storage proteins and transport proteins to protect those free metals from entering the Fenton reaction. So iron is often found bound to either transferrin, ferritin, or lactoferrin. Copper is found bound to ceruloplasmin. And the reason we have these proteins is that binds the transition metal and keeps it from entering the Fenton reaction and generating free radicals. Another source of free radicals inside the body is the respiratory burst. This is something that phagocytes do when they have engulfed bacteria inside the phagosome in order to kill the bacteria. One of the ways that phagocytes can kill bacteria is by generating hydrogen peroxide inside the phagosome where the bacteria is found. So if you look on the screen here, what phagocytes do is they bind to the bacteria or whatever invader is in the body. They place it inside a small package inside the cell called a phagosome. And then what they do is they use a biochemical process called the respiratory burst to generate hydrogen peroxide in order to kill the bacteria. The generation of hydrogen peroxide by the respiratory burst requires three key enzymes. The first one is NADPH oxidase, the second one is superoxide dismutase, and the last one is myeloperoxidase. And here's how the respiratory burst works. Phagocytes begin with oxygen. The enzyme NADPH oxidase, an enzyme which requires NADPH, converts oxygen into superoxide. Then superoxide dismutase synthesizes hydrogen peroxide, and then myeloperoxidase uses chloride to create hypochlorous acid. And all of these substances here contribute to bacterial death inside of phagocytes. So now we've talked about ways that free radicals are generated inside our body, things like oxidative phosphorylation, radiation, etc. Now let's talk about some of the ways that our body inactivates free radicals so they can maintain a low level under normal conditions. Well, first of all, free radicals spontaneously decay, so to some degree they just go away on their own. In addition, antioxidants are substances inside of cells that are free radical scavengers, and these bind free radicals and eliminate them, and this protects the cell from free radical damage. So vitamin E, vitamin A, and vitamin C are all antioxidants, and so is the substance glutathione. There are also enzymes in our body that can inactivate free radicals. Catalase is found in the peroxisomes in our body. Superoxide dismutase is found in the mitochondria, and we talked earlier about how this can eliminate free radicals generated by oxidative phosphorylation, which occurs in the mitochondria. Glutathione peroxidase is another enzyme in cells. It's found in the cytoplasm. It gets its name because it requires glutathione, and it uses glutathione to inactivate hydrogen peroxide and turn it into water. And I've shown this at the bottom of the screen. So oxygen can be converted into all of these free radicals, and catalase, peroxidase, and superoxide dismutase all in one way or another help to convert those free radicals into water. There are two super high yield disorders that the boards love to test you on. They're both very rare, but they have tie-ins to everything we've been talking about up to this point regarding free radicals. The first one is CGD, or chronic granulomatous disease. People with this disorder have an immune deficiency syndrome and are vulnerable to infections. The underlying problem is that they lack normal functioning of NADPH oxidase, that enzyme we talked about being part of the respiratory burst. This means that for these patients, their phagocytes cannot generate hydrogen peroxide, and therefore they cannot effectively kill bacteria. If we go back to this slide, patients who are defective in this enzyme can't generate any of these free radicals to cause bacterial death. It turns out, however, that they are not vulnerable to infections by every organism. Some organisms they can fight off. Bacteria can be either catalase positive or catalase negative. The catalase enzyme, if bacteria have it, in other words, if they're catalase positive, allows the bacteria to break down hydrogen peroxide. If we go back to this slide, this is what catalase does in our own body. It converts hydrogen peroxide into water. Well, some bacteria are catalase positive, and they also have the ability to convert hydrogen peroxide into water. In those catalase positive bacteria, there is not going to be any hydrogen peroxide around, even inside the bacteria. So patients with CJD cannot generate their own hydrogen peroxide and free radicals, and they also cannot find any inside the cell if they are infected with catalase positive bacteria, and this leads to recurrent infections. Bacteria that are catalase negative, however, will generate their own hydrogen peroxide. This can be generated as part of normal bacterial metabolism. And when this happens, the phagocytes can use the H2O2 from the bacteria and create free radicals. If we go back to this slide, bacteria that lack the catalase enzyme will synthesize some hydrogen peroxide as part of normal metabolism. Myeloperoxidase can use that hydrogen peroxide to make hypochlorous acid, and together the phagocyte can use these two substances to cause bacterial death. Thus, they are more able to kill catalase-negative bacteria compared to catalase-positive bacteria that do not generate hydrogen peroxide. And so because of all this biology related to the catalase enzyme and free radicals and the respiratory burst, there are 5 organisms that cause most of the infections in patients with CJD. They're shown on this slide here, and all of these are catalase positive. They break down their hydrogen peroxide and don't leave any for the phagocyte to use. The second super high yield disorder when it comes to free radicals is G6PD deficiency. In the biochemistry video on the HMP shunt, I talk about this disorder in detail. It's an enzyme deficiency disorder where patients can't synthesize normal quantities of NADPH. But for our purposes here, I want to focus on the free radical aspects of this disorder. Patients with G6PD deficiency have a limited supply of glutathione, and this makes them vulnerable to red blood cell damage by free radicals, which leads to recurrent episodes of hemolysis. That's the hallmark of this disorder, is recurrent hemolysis. And one of the classic triggers for hemolysis in patients with this disorder is fava beans. G6PD deficiency occurs in some parts of the world where people eat lots of fava beans. And if they have this condition and they eat fava beans, they will develop hemolysis. The reason this happens is because fava beans contain a compound known as visine. This is its structure on the bottom left side of the screen. It's metabolized in our body to divesine, which can generate reactive oxygen species. So first of all, when you eat fava beans, you generate more reactive oxygen species and more free radicals. In addition, our cells try to inactivate the reactive oxygen species by using glutathione, but these patients have a limited supply, and therefore they run out of glutathione and they suffer from hemolysis. If we go back to this slide, one of the mechanisms for free radical inactivation is the enzyme glutathione peroxidase. It's found in the cytoplasm of cells, including in red cells. It requires glutathione to function, and it uses glutathione to convert hydrogen peroxide into water. So in a person with G6PD deficiency, there's a limited supply of glutathione, and this leads to an inability to inactivate free radicals, and that leads to free radical damage and hemolysis. So now that we've talked about how free radicals are generated and how they're inactivated, let's talk about exactly how they are toxic to cells. I told you before that cells don't like free radicals, but now let's talk about why that's the case. Basically, free radicals do 3 major things that are bad for cells. The first thing is they peroxidize lipids, and it's very high yield to know this. A peroxide is a substance with 2 oxygens bound together. And if you look at the right side of the screen, you can see how lipids can get peroxidized by free radicals. So any lipid that is unsaturated, meaning it has at least one double bond, can react with free radicals and become a lipid radical. That lipid radical can then react with oxygen, and ultimately what you end up with is a lipid peroxide. These are not good for cells. When they occur in lipids of the cell membrane, they damage the membranes. And this is one of the ways by which free radicals can damage cells. In addition, free radicals can oxidize proteins, and this damages important enzymes inside the cell. And they can also disrupt DNA. They can cause breaks in DNA and cross-linking. And all of these things are how high levels of free radicals are damaging to our cells. So now I'll finish this video with a couple of clinical examples of free radical induced injury. And the first one we'll talk about is called reperfusion injury. So when patients have a myocardial infarction, which I talk about in detail in the cardiology section, there's decreased blood flow to the myocardium. This is an example of ischemia. When that myocardial infarction is treated and the thrombus in the artery resolves or is treated with angioplasty, blood flow is restored. This is called reperfusion, and blood flow returns to the myocardium. When you do this, this is overall a good thing for patients. Some reversibly injured cells recover, and there's less myocardial damage overall. However, people have studied this in detail in the basic science laboratory, and it turns out that some cells are actually damaged by reperfusion. This is bad, and it's paradoxical because we think that restoring blood flow is good, so it's a surprise that it turns out it's bad in some cases. There are several mechanisms behind this, but one of them is the fact that when you restore the oxygen supply to the myocardium, you generate free radicals, especially in areas of the myocardium that have been damaged. Those areas have lost antioxidants, and they're less able to tolerate the free radicals that come with the resupply of oxygen. In addition, mitochondria have been damaged, and they can only incompletely reduce oxygen, so they generate more free radicals than usual. So for both of these reasons, reperfusion damages myocardium to some degree, even though overall it is a beneficial thing for patients. Another example of free radical damage is carbon tetrachloride. This is an industrial solvent that used to be used in the dry cleaning industry, but it's now banned because the liver is highly sensitive to damage in people exposed to this over time. The reason damage to the liver occurs is because carbon tetrachloride is converted to CCl3, which is a free radical, by P450 enzymes in the liver, just like we talked about earlier. This leads to lipid peroxidation, as we talked about earlier, as a consequence of free radical damage. In addition, in the liver, what happens is lipoproteins are no longer synthesized and secreted normally, so there's an accumulation of lipids. So the classic finding in a patient years ago who had carbon tetrachloride poisoning was that their liver would be filled up with fat. Eventually, the buildup with fat and other consequences of free radicals would lead to cell death and liver failure. And I'll finish this video with lipofuscin. This is an insoluble cellular pigment. It has a yellow-brown color that I'll show you in a minute, and it's commonly seen on examination of biopsy specimens. Lipofuscin contains oxidized lipids. It's made up of oxidized lipids, and these are thought to be derived from lipid peroxidation from free radicals like we talked about earlier. As we get older, over time, lipofuscin accumulates in our lysosomes, and that's why you can see it on biopsy specimens. The good news is it's generally not pathological, meaning it does not cause disease. However, it is seen as people age. So when you examine biopsy slides of older patients, you will commonly see lipofuscin. It does not mean there's any disease process going on. It's just a sign of aging. And here's a biopsy slide of muscle tissue and the arrows pointing to the yellow-brown lipofuscin pigment, a common finding when you examine tissue in biopsies of older patients. And that concludes our video on free radicals. Hi, everybody, and welcome to our module on apoptosis. Apoptosis is also called programmed cell death, and it gets its name because the cell uses its own machinery, its own programming to destroy itself. The cell activates its own enzymes, and this leads to cell death. In contrast to necrosis, apoptosis is a very orderly process. The cell membranes remain intact, inflammation is not activated, and ultimately phagocytes will consume the cell that has died. A single cell can undergo apoptosis without disturbing any of its neighbors, and this is in sharp contrast to necrosis. In necrosis, the cell basically falls apart. This triggers inflammation, and often multiple cells die at the same time. That is not true for apoptosis, and for that reason, this is the preferred way for cells to die in the body because it's neat and orderly and doesn't destroy any other tissue. Apoptosis is an active process. It is ATP dependent. It requires an energy investment by the cell. And this is in contrast with necrosis, which does not require energy. And the idea here is that in apoptosis, the cell uses its energy so it can die in an orderly way and preserve the overall organism. In contrast, necrosis is where a cell dies in a disorderly way. This leads to inflammation and often damages surrounding tissue. And we're learning more and more that many stimuli that we used to think cause only necrosis actually may cause both apoptosis and necrosis. For example, myocardial ischemia was historically thought to lead to necrosis, and it does, but there's now evidence that it actually leads to both forms of cell death, apoptosis and necrosis. What it looks like happens is that initially when there is ischemia, cells undergo apoptosis. This lets some cells die in an orderly way and avoids inflammation and necrosis. However, later those myocytes run out of ATP and they can't die by apoptosis because that requires ATP. At this point, the cell becomes damaged and undergoes necrosis. And there's more and more evidence that apoptosis and necrosis are linked in this way, and that the body tries to have cells undergo apoptosis first and only proceeds to necrosis when apoptosis fails, often from depletion of energy. Let's talk about some causes of apoptosis. Why would a cell undergo apoptosis? Well, first of all, apoptosis is a normal part of embryogenesis. Many cells develop in the embryo but do not persist into the newborn baby and adulthood. This is part of the normal development of the fetus. When hormones are withdrawn, many tissues undergo apoptosis. There are many so-called hormone-dependent tissues, and when you withdraw the hormone, those cells die by apoptosis, which is much better than dying by necrosis, which would cause inflammation. So, for example, the endometrium can grow when stimulated by progesterone, but when that is withdrawn as part of the endometrial cycle, apoptosis occurs. And it's good that apoptosis occurs because if it didn't and necrosis happened, you would have an inflamed uterus every time the menstrual period occurred. Immune cells often undergo apoptosis. T cells in the thymus do this, so do B cells in the germinal centers of lymph nodes. In the thymus, cells that react with self-antigens, T cells, will undergo apoptosis so that they won't survive to attack the body itself. In germinal centers, when you have inflammation, B cells multiply, but when the immune stimulus is resolved, those B cells undergo apoptosis, so they die in an orderly manner without causing the lymph node to become inflamed from necrosis. When DNA damage is detected inside of cells, those cells will often undergo apoptosis. Cells that are abnormal in any way, their machinery is off, their proteins are off, this is often detected, and the cell undergoes apoptosis. And then finally, many infected cells, especially those infected with a virus, will undergo apoptosis. We'll talk later about how CD8 T cells can actually trigger this process to occur. So there's lots of basic science literature on how apoptosis occurs. The reason this has been so heavily studied is because many cancers develop from failure of apoptosis. A cell that is abnormal should undergo programmed cell death, but this doesn't occur, and the cell is allowed to grow and multiply and ultimately becomes a tumor. So let's talk about some of the current understanding of the mechanisms of apoptosis. The first thing to know is that enzymes called caspases are critical to apoptosis. These enzymes are found in the cytosol in an inactive state, but when they become activated by a variety of triggers, this can lead to apoptosis. There are two pathways that have been described that lead to caspase activation. The first one is called the intrinsic or mitochondrial pathway, and this gets its name because this pathway is initiated by the mitochondria, which is inside or intrinsic to the cell. The second pathway is called the extrinsic or death receptor pathway, and this gets its name because this is activated by things outside or extrinsic to the cell, and it happens because of interaction with death receptors found on the cell membrane. Let's talk about the intrinsic pathway first. This pathway begins with opening of pores in the mitochondrial membranes. And when they open, they allow cytochrome C to release into the cytoplasm. By way of review, here's a slide from the biochemistry video on electron transport, and cytochrome C participates in electron transport by transporting electrons from complex 3 to complex 4. It's also used as a trigger for apoptosis when cytochrome C is released into the cytosol. What cytochrome C does is it binds to something known as APAF1 or apoptosis activating factor 1, and this can activate caspase enzymes. The ability of cytochrome C to get into the cytoplasm and activate caspases is controlled by a family of proteins called BCL2 proteins. Some of these are pro-apoptotic, meaning they favor apoptosis, and some are anti-apoptotic. And the balance of activity determines whether a cell undergoes apoptosis. So if the pro-apoptosis proteins are more active, then the cell will undergo apoptosis. If the anti-proteins are more active, then the cell will not undergo apoptosis. There are many proteins that have been described that are part of the BCL2 family. Some that have been described that are anti-apoptosis include BCL2, BCLXL, and MCL1. These are found in the membranes of the mitochondria, and they basically keep the membrane intact and prevent cytochrome C from leaking out into the cytosol, where it can go on to activate caspases. BCL2 family proteins that are pro-apoptosis include BAX and BAC. These are the two famous ones. They bind to these anti-apoptosis proteins and stop them from doing their job. This opens pores in the mitochondrial membrane and allows cytochrome C to leak out. Therefore, BAX and BAC promote apoptosis. And an easy way to remember this is that the BCL2 proteins with an A in their name are for apoptosis. They cause apoptosis. That's BAX and BAC. Those are the ones with the A in their name. All of these anti-apoptosis proteins do not have an A in their name. And here's my own little drawing of how the intrinsic pathway works, which I show you to help you remember it. Keep in mind, however, that the actual intrinsic pathway is far more complicated than this. This is an oversimplification, just so you can remember the details for your boards. So under normal circumstances, cytochrome C is found within the mitochondria, and BCL2 and other anti-apoptotic proteins are keeping it inside the mitochondrial membrane. If a trigger activates BAX or BAC, they can move the anti-apoptotic proteins out of the way. This allows cytochrome C to come out into the cytosol. It interacts with APAF1 and activates caspases. A very high-yield clinical example of the intrinsic pathway gone awry is follicular lymphoma. This is a subtype of non-Hodgkin lymphoma that I discuss in the hematology section. It's a B-cell malignancy. And this malignancy has been shown to overexpress BCL2. And remember what I told you, BCL2 is anti-apoptosis. So when there's overexpression of this protein, those mitochondrial pores will never open. This means caspases cannot be activated and the cells will never undergo apoptosis. That leads to uncontrolled cell growth. And as I told you before, many malignancies are believed to derive from a failure of apoptosis. And this is an example of one that has been specifically tied to one of the BCL proteins. Let's talk about some of the triggers for the intrinsic pathway of apoptosis. If a growth factor is withdrawn, cells will often undergo the intrinsic pathway and undergo apoptosis. So in hormone-sensitive tissues like the uterus, if the hormones are withdrawn, that will lead to cells undergoing apoptosis by the intrinsic pathway. Cytokines drive the growth of immune cells, but when those cytokines go away, those immune cells will undergo apoptosis by the intrinsic pathway. And also the intrinsic pathway is heavily involved in embryogenesis. When DNA damage occurs, either from radiation or there are many chemotherapy agents that damage DNA, this can lead to activation of BAC and BAX, which are pro-apoptosis. The protein P53, which I talk about in other videos, is an activator of BAC and BAX. And then finally, if there are abnormal proteins inside a cell, this can happen when there's heat exposure or hypoxia or low glucose. This can often trigger apoptosis via the intrinsic pathway. Now let's talk about the extrinsic pathway of apoptosis. This pathway involves death receptors. These are found on the surface of cells, and when they're activated, they lead to apoptosis. All of the death receptors are part of a family of receptors called the TNF family, or the tumor necrosis factor family, and they span the plasma membrane and spread into the cytoplasm from the outside of the cell. One of the best described death receptors is called FAS. It's also called CD95. It can bind to the FAST ligand, and when this happens, this triggers a sequence that leads to the activation of caspases and therefore apoptosis via the extrinsic pathway. So let's go through some examples of apoptosis via the extrinsic pathway. One of the best examples is when a CD8 positive T cell kills a virally infected cell. And I talk about this in more detail in videos in the immunology section. When a cell is infected with a virus, that cell can present viral antigens on the cell surface via MHC class 1. MHC class 1 can bind to CD8 T cells, and when this happens, the CD8 cells will release substances called perforin and granzymes into the virally infected cell. One of the first things that can happen is these perforins and granzymes can direct infected with a virus. That cell can present viral antigens on the cell surface via MHC class 1. MHC class 1 can bind to CD8 T cells, and when this happens, the CD8 cells will release substances called perforin and granzymes into the virally infected cell. One of the first things that can happen is these perforins and granzymes can directly activate caspases, leading to apoptosis. But in addition, CD8 T cells produce the Fas ligand, and that can bind to Fas or CD95 on the surface of virally infected cells, and this also can activate the extrinsic pathway apoptosis so that the cell infected with the virus will die. Another example of the extrinsic pathway is the thymic medulla, and we mentioned this earlier. T cells that bind to self-antigens in the thymus will die. This is called negative selection, which I talk about in videos in the immunology section. And when T cells bind self-antigens, death will occur via apoptosis via the extrinsic pathway, and this has to do with Fas ligand interactions. This interaction occurs between T cells and thymus cells, and that leads to apoptosis. There is a rare disorder called autoimmune lymphoproliferative syndrome, and the reason you should know about this for step 1 is because the underlying cause is a defective Fas ligand pathway for apoptosis. In this disorder, Fas and Fas ligand do not normally bind to each other and trigger apoptosis. For this reason, there is poor negative selection in the thymus. This means that many T cells that bind self-antigens will survive. This leads to an overproduction of lymphocytes, and you have lots of T cells around that can react to some degree with self-antigens. So this can lead to lymphadenopathy, hepatomegaly, and splenomegaly. This is all due to lymphocytes in these organs and structures that are growing by reacting with self-antigens. There's a very high risk of developing lymphoma, and there are many autoimmune diseases. The details of this disorder are not important, but you should understand that it is caused by a defective interaction between Fas and Fas ligand and an ineffective extrinsic pathway occurring among T cells in the thymus. So now let's talk about some of the cellular changes you can see under the microscope if you watch cells as they undergo apoptosis. First of all, cells undergoing apoptosis will shrink, and this is in contrast to necrosis. Cells undergoing cell death via necrosis always swell. Second classic change is chromatin condensation in the nucleus. This is also called pyknosis. You will see the nucleus condensing. This is shown on this slide on the screen here. Parts of the nucleus clump together and become dark, and this is one of the hallmarks of apoptosis. The membranes of cells undergoing apoptosis will form blebs. This is also seen in necrosis. So if we look at my slide on the screen here, the top is a normal cell. In the middle panel, the cell is undergoing apoptosis. So you can see that the nucleus is condensing and these blebs are beginning to form in the membrane. The cell is shrinking as well. And then finally, what the cell does is it basically explodes and releases these small little packages of parts of the cell. These are called apoptotic bodies. They're fragments of the membrane that contain cellular organelles, and they contain ligands for phagocyte receptors. So phagocytes will recognize apoptotic bodies and consume them. This is shown in the bottom slide. The cell breaks apart, forming these little packages, the apoptotic bodies, and they get eaten up by the phagocytes. This is a nice orderly process of cell death. It does not cause inflammation, and it's the preferred way of the body to have cells undergo cell death. I'll briefly mention DNA laddering. This is a technique used in the laboratory to identify that cells have undergone apoptosis. One of the things that apoptotic caspases can do is to cleave DNA, and when they do so, they cleave it at very specific regions. and they always form pieces that are multiples of 180 to 185 kilobase pairs. So for example, one piece might be 180 kilobase pairs, another piece might be 2 times 180 kilobase pairs, and another piece might be 3, and so on. But they're always multiples of 180 to 185. When you spread these out on a gel, you form a ladder of sizes as shown in the bottom right side of the screen. And when you see this nice orderly ladder where the pieces are all multiples of 180, you know that apoptosis has occurred. In contrast, cells that undergo necrosis have random fracturing of the DNA, and this leaves pieces of DNA that are multiple different fragment lengths in size with no association to one another. I'll finish with this slide highlighting some of the differences between apoptosis and necrosis. Apoptosis is non-inflammatory, whereas necrosis evokes an inflammatory response that can damage neighboring cells and tissues. Cells shrink in apoptosis, they swell in necrosis. Membrane blebbing is common to both modes of cell death. The membrane remains intact in apoptosis as apoptotic bodies are formed. The membrane is damaged and contents of the cell leak out in necrosis. A single cell can be affected by apoptosis without disturbing its neighbors. In contrast, necrosis rarely happens to a single cell. It usually happens to tissue beds, and the inflammation of necrosis draws in other cells to the area of damage. DNA laddering is seen in apoptosis. It's not seen in necrosis. And then finally, apoptosis can be physiologic. For example, it can be part of embryogenesis or part of the menstrual cycle. However, necrosis is always pathological. It always means some pathologic disorder is occurring. And that concludes our video on apoptosis. Hi, everybody, and welcome to our module on necrosis. In the video on cell injury, I talk about necrosis. It's one of the forms of cell death. The other one is apoptosis. And in necrosis, the cell membrane is lost and cellular contents leak out, and this elicits an inflammatory response. In this video, I'm not going to talk about the cellular changes of necrosis, but I'm going to talk about what happens in the tissue beds that undergo necrosis. Necrosis rarely affects a single cell. It usually affects multiple cells and entire tissue beds or even entire organs. For this reason, there are a number of classic gross and microscopic changes that you can see in tissues undergoing necrosis, and that's what we're going to focus on in this video. Tissue that's undergone necrosis is examined by pathologists in two ways. First of all, they look at the gross structure of the tissue bed that's undergone necrosis, and secondly, they look at specimens under the microscope. Based on those gross and microscopic findings, necrosis can be categorized into a number of types. The two major types are coagulative and liquefactive, and we'll talk about those in this video. There are also some less common types, and these include caseous, fibrinoid, fat necrosis, and gangrenous necrosis, and we'll also talk about all of these. But the point to understand is that these are all determined based on what the tissue that has undergone necrosis looks like, either grossly or under the microscope. We'll start by talking about coagulative necrosis, which is the most common form of necrosis. The hallmark of this form of necrosis is that the tissue architecture is maintained for several days, and this is a key point. The tissue does not just fall apart, but it maintains to some degree its original shape and architecture. The reason this type of necrosis occurs instead of some other type is because the injury that causes cell death and necrosis also damages cellular enzymes, and this is the major distinction between coagulative and liquefactive necrosis. When the enzymes are damaged, there's limited proteolysis because the enzymes are gone from the cells. As a result, much of the tissue shape and architecture can remain intact for several days after necrosis begins. During this time, there's phagocytosis of the cell remnants. This takes a while, and as this is going on, the tissue will maintain its normal architecture. When you examine an organ or a gross specimen that has undergone coagulative necrosis, the main feature is that it's very firm. That's from the influx of inflammatory cells. When you look at the tissue under the microscope, the architecture is specimen phagocytosis of the cell remnants. This takes a while, and as this is going on, the tissue will maintain its normal architecture. When you examine an organ or a gross specimen that has undergone coagulative necrosis, the main feature is that it's very firm. That's from the influx of inflammatory cells. When you look at the tissue under the microscope, the architecture is preserved, but the cells have been damaged and they've lost their nuclei. There's a red-pink color when you use H&E staining, and that's because the damaged cells take up more stain because their membranes are destroyed. And you will also see an influx of inflammatory cells. This slide shows an ischemic infarct of the kidneys. You can see this white pale area. That is an area undergoing coagulative necrosis. If you could touch this kidney, you would see that this area is relatively firm compared to the rest of the organ. And that's the gross finding in an organ that has suffered from coagulative necrosis. Under the microscope, what you see is that the tissue architecture is maintained. So on the left side of the screen is a normal heart. On the right side of the screen is myocardial tissue after an infarction. And you can see that you still see the wavy lines of the myocytes. The tissue architecture is somewhat preserved. You also see lots of these little dark purple spots. Those are the nuclei of white blood cells, which have infiltrated the area. But importantly, this area of the heart has not been completely liquefied or destroyed. If that had happened, we would have a different type of necrosis. So the classic causes of coagulative necrosis are infarctions or ischemia. This is what you see in the myocardium when there's myocardial ischemia. You also see it in the kidneys and the spleen when either of these organs suffer from ischemia and poor blood flow. The one exception is the brain. For reasons that are poorly understood, the brain does not undergo coagulative necrosis. It undergoes liquefactive necrosis, which we'll talk about next. So that's a nice segue into liquefactive necrosis, which is the second type of necrosis. And usually this is caused by an infection. So abscesses, like bacterial or fungal abscesses, can destroy a tissue bed. And what they leave behind is an area of liquefactive necrosis, not coagulative necrosis. The one non-infectious place where you can see this is in the brain, as I just mentioned. The reason why the brain undergoes liquefactive necrosis is poorly understood. The cause of liquefactive necrosis in infections is that inflammatory cells are drawn in and the tissue becomes liquefied into a thick liquid mass. That's why it's called liquefactive necrosis. What destroys the tissue are enzymes from the microbes and also enzymes from the lysosomes of dying cells. Like I told you earlier, in this form of necrosis, the cellular enzymes are intact and they can destroy the tissue, as opposed to coagulative necrosis, where the cellular enzymes are often destroyed as part of the necrotic process. When you examine an organ or tissue that has undergone liquefactive necrosis, what you see grossly is just liquid or pus, or maybe just a cavity that's left behind. Microscopically, what you see are numerous neutrophils and the tissue architecture has been destroyed. So here's a picture of an area of the brain that has suffered a stroke, and you can see it's just a hole. The tissue has been liquefied, it's basically gone, and that's an example of liquefactive necrosis. And here's what the brain looks like after a stroke under the microscope. You can see this large area here where the tissue has just been destroyed. There's nothing left. It's got inflammatory cells. It's also just got a lot of empty spaces. The underlying tissue architecture is no longer present. So coagulative and liquefactive necrosis are the two main types of necrosis. But what I'm going to talk about now are some less common types that you generally see only in specific situations. The first type is caseous necrosis. The word caseous means cheese-like, and that's because grossly this type of necrosis looks like cheese. I'll show you a picture of it in a minute. You rarely see this outside of a tuberculosis infection. Caseous necrosis is the classic finding in an organ that has been infected with Mycobacterium tuberculosis. The reason this occurs is because mycobacteria are very resistant to digestion by phagocytes. For this reason, macrophages are chronically stimulated and they form giant cells and go on to cause granuloma formation. And I talk about this in the video on granulomatous inflammation. In tuberculosis, there's generally a slow breakdown of infection for all these reasons, and lots of the mycolic acid from the mycobacteria and other lipids accumulate, and this is what gives the organ a cheese-like appearance. When you examine an organ that has undergone caseous necrosis, what you see grossly is a cheese-like caseating substance. I'll show you a picture of this in a minute. Microscopically, what you see is granulomatous inflammation. However, there is a necrotic center, and that's what is forming the cheesy-like substance that you see grossly. Otherwise, the findings are typical of granulomas, which I talk about in another video. There's a ring of lymphocytes and macrophages surrounding epithelioid cells and giant cells, which are fused activated macrophages. Here's a picture of a lung that was infected with tuberculosis, and you can see why it's called caseous necrosis. This area of necrosis looks like cottage cheese. And here's an example of a caseating granuloma under the microscope. You have this ring of lymphocytes around the outside. In the middle, you can find epithelioid cells and giant cells, but importantly, you have this area of necrosis. It's just pink material in the middle, and you can see why it's called caseous necrosis. This area of necrosis looks like cottage cheese. And here's an example of a caseating granuloma under the microscope. You have this ring of lymphocytes around the outside. In the middle, you can find epithelioid cells and giant cells, but importantly, you have this area of necrosis. It's just pink material in the middle, and that is what contributes to the caseous cheese-like finding in gross pathology. Fat necrosis, as the name implies, is necrosis of fat, and the classic example of this is acute pancreatitis. In acute pancreatitis, lipase enzymes are released from pancreatic cells. These are enzymes that normally travel to the digestive tract to break down lipids, but in acute pancreatitis, they leak and begin to damage the pancreas itself. One thing they do is break down peritoneal fat, and that peritoneal fat releases fatty acids which combine with calcium. This is a process called saponification, and this leads to formation of a chalky white tissue, which is classic in acute pancreatitis and fat necrosis. This is a gross specimen from someone who died with acute pancreatitis, and you can see these white clumps here. This is fat that has undergone saponification with calcium and undergone fat necrosis. A second place where you can see fat necrosis is in the breast, and this is a big problem for doctors who treat breast cancer and breast radiologists because this can mimic breast cancer. So women who have trauma to the breast can develop fat necrosis of the fatty tissue in the breast. Often this is after a biopsy or surgery on the breast, but it can also be from a sports injury or a seatbelt injury. And unfortunately, many women develop fat necrosis without recalling the injury because it didn't seem that bad at the time. And they will present with a lump that can mimic breast cancer, and it can be hard to differentiate this from malignancies of the breast. And this is a picture of fat necrosis of the breast, very easy to recognize under the microscope because of the big lobules of fat. Gangrenous necrosis is a subtype of coagulative necrosis, but it gets its own name because there's a characteristic way that tissues look when they undergo this type of coagulative necrosis. It's always caused by ischemia, and the two main places it occurs is in the limbs, especially the feet or toes, and in the bowel. These places can lose their blood supply and develop gangrenous necrosis. When there is ischemia to these areas, multiple tissue layers are involved, and it gives a characteristic appearance when you look at the tissue grossly. You can break down gangrenous necrosis into either dry or wet gangrene. In dry gangrene, this happens in the feet of people with peripheral vascular disease. The skin will be dry, but it will be black, and the tissue will be shrunken. I'll show you a picture of that in a minute. Wet gangrene is when dry gangrene has a superimposed bacterial infection. What's happening here is that you have the coagulative necrosis of gangrene, but also liquefactive necrosis from an infection. And as a result, the tissue looks moist, soft, and swollen. Because it's moist, it's called wet gangrene. There's often pus from the infection, and it's very foul smelling. If you ever see a patient with this, you will never forget because it smells horrible. So this is an example of dry gangrene. This is someone with peripheral vascular disease, and you can see how black the toes are. You can see that the skin tissue is pulled tightly together. This is dry gangrene. And here's an example of wet gangrene. So you can see that the tissue is swollen. It's also moist. If you could touch it, and it would have a very foul smell. This is wet gangrene. Both types are caused by a loss of blood supply, but this type has a superimposed infection. Our last type of necrosis is fibrinoid necrosis, and this only occurs in blood vessels, and you can only see it under the microscope. There are no gross findings. The classic cause of fibrinoid necrosis is autoimmune disorders. In some autoimmune disorders, which I talk about in other videos, antibody-antigen complexes deposit in the vessel wall. This is an example of a type 3 hypersensitivity reaction. When this occurs, fibrin leaks into the vessel wall and gives a pink appearance on microscopy, and that's why this is called fibrinoid necrosis. And here's an example of what this looks like under the microscope. This is a blood vessel here. You can see the red blood cells, and there's pink material in the vessel wall. That is evidence of fibrinoid necrosis. You can see fibrinoid necrosis in a number of autoimmune disorders, but you should know, especially for step 1, that the classic disorder is polyarteritis nodosa. I talk about this in the video on vasculitis in the immunology section, but people with polyarteritis nodosa develop purpura on their skin, they develop renal failure, and they develop neuropathy. And the classic finding on biopsy of a blood vessel in a patient with PAN is fibrinoid necrosis. The other place you can see fibrinoid necrosis that you should know for step 1 is patients with severe hypertension or women with preeclampsia. In this case, it's not autoimmune like it is in polyarteritis. What's happening here is there's damage to the vessel wall and fibrin is leaking out, and that also can lead to fibrinoid necrosis. And that concludes our video on necrosis.
Finish all of this now.
Hi, everybody, and welcome to our module on inflammation principles. Inflammation is the body's process for eliminating pathogens like bacteria and other infectious agents, and also damaged tissue. For example, if tissue is damaged by trauma or surgery, it will heal through the process of inflammation. So this means that inflammation is very common to many of the things we see in our patients every day, things like infections and trauma and surgery. Now, even though inflammation is a good thing, it's the body's process for defending itself and for healing, it can cause damage to the host as well. For example, in sepsis, there's excessive inflammation, which damages the entire body. Inflammation can be prolonged. Some infections fail to resolve, and this can lead to chronic inflammation, which we'll talk about later. And sometimes inflammation is inappropriate. This is the underlying basis of autoimmune diseases. It's inflammation where you don't want it, directed against the body itself. We characterize inflammation as either acute or chronic. Acute inflammation has a rapid onset, usually in minutes to hours, and it resolves quickly, usually within a few days. If you've ever had a sore throat, that's an example of acute inflammation. Comes on quickly and goes away within a few days. In contrast, chronic inflammation is a special form of inflammation that can last for weeks, months, or years. And in another video, I talk in detail about the differences between acute and chronic inflammation. What I'm going to do in this video is talk about the underlying basis of inflammation, whether it is the acute or chronic form. The things we'll discuss in this video are generally seen in both acute and chronic inflammation. Inflammation has 5 so-called cardinal signs. These are the physical manifestations of inflammation that you can see with any form of inflammation. And these were described hundreds of years ago by the ancient Romans, and they're still true today. So the first cardinal sign is rubor, which means redness, and the second cardinal sign is calor, which means warmth. And both of these features, redness and warmth, are caused by vasodilation and increased blood flow to areas of inflammation. Third cardinal sign is tumor, which means swelling, and this is caused by increased vascular permeability that allows cells and proteins, including complement and other important inflammatory proteins to be drawn into sites of inflammation. Fourth cardinal sign is dolor, which is pain. If you've ever had a swollen wrist where you've injured it, or a swollen arm or elbow, you know that it can be painful when your body is inflamed. And then the last cardinal sign is loss of function. This is caused by the other cardinal features. When you have a warm, swollen, painful joint or other part of your body, it's very hard to use that part of your body, and therefore you lose function. There are many clinical disorders that present with the 5 cardinal signs of inflammation, but one that's easy to get your mind around is an acute attack of gout. Gout is a joint disease that typically attacks the big toe, and this is an example of it right here. This person's big toe is red and swollen. If you could touch it, it would be warm. It's very painful to the touch, and because of that pain, it will be difficult for this person to bear weight on his or her foot. So all the 5 cardinal signs of inflammation manifesting in an acute attack of gout. For step 1 of your boards, they're going to want you to understand the underlying mechanisms of those 5 cardinal signs. So let's talk about them now. First, let's talk about vasodilation, which occurs in inflammation. This is what leads to redness and warmth, rubor and calor, like we talked about before. As you may know, if you've watched the cardiology videos, the main vessels in our body that vasodilate and vasoconstrict are the arterioles, and that's also true here. In the setting of inflammation, there is arteriolar vasodilation, and this increases the blood flow to areas of inflammation. So if you look at this drawing on the screen, the capillaries are in the middle, the venous system is on the right, the arterial system is on the left. These arterioles here will vasodilate, and that will draw blood into the capillary system of an area of inflammation. There are a number of substances that are released by cells in the setting of inflammation that trigger vasodilation, but 2 that you should definitely know about are histamine and prostaglandins. Histamine is a small molecule. This is its structure shown on the screen. It is stored inside of mast cells, basophils, and platelets. And these cells preform this. In other words, they make it outside of the setting of inflammation, and they have it ready to go. So when there's an inflammatory trigger, histamine is released quickly and causes vasodilation. And that is one of the factors that leads to the rubor and calor like seen on this person's foot on the screen. Second important trigger for vasodilation are prostaglandins. These are released in the setting of inflammation by mast cells and leukocytes, and they are actually not preformed. They are synthesized when inflammation occurs, and they are derived from arachidonic acid. This is the structure of prostaglandin E2 shown on the screen here. Note that it's a much bigger molecule than histamine. Note also that it contains lots of carbons and hydrogens, and therefore it is a lipid structure, and it's derived from lipids. Prostaglandins are an example of a signaling molecule called an eicosanoid. Other eicosanoids include leukotrienes and thromboxanes, and all of these substances are derived from arachidonic acid. They're sometimes referred to as arachidonic acid derivatives. The way this works is, in the setting of inflammation, phospholipase A2, an enzyme found inside of cells, pulls lipids from the cell membranes to make arachidonic acid. This is its structure shown on the screen here. Note that it's a large hydrocarbon structure, and that should make sense to you because it comes from lipids. From arachidonic acid, there is an enzyme called lipoxygenase, which can make leukotrienes. There's also an enzyme called cyclooxygenase, which can synthesize thromboxanes and prostaglandins. And prostaglandins are some of the substances that cause vasodilation in the setting of inflammation. Another important substance that triggers vasodilation in the setting of inflammation is bradykinin. And bradykinin is interesting because it is linked to the clotting cascade. In the setting of inflammation, there's an increase in clotting factors, including factor 12, which is the Hageman factor. This is a component of the clotting cascade that I talk about in the hematology section, although it has a very minor role in the clotting system. Its more important role is that it leads to the production of bradykinin. Activated factor 12 can convert a substance called prekallikrein into kallikrein, and then kallikrein can convert a substance called high molecular weight kininogen into bradykinin. These substances are around in the setting of inflammation, and therefore when factor 12 becomes activated, that leads to more production of bradykinin. Bradykinin is a vasodilator and therefore contributes to the vasodilation seen in inflammation. It also increases vascular permeability, which we'll talk about in a minute, and that leads to swelling and inflammation. It's also important as a cause of pain. It triggers pain in our nerve fibers. An easy way to remember this is that the B in bradykinin is for boo-boo, like when you fall and hurt yourself and get a boo-boo. 2 other important things, especially for step 1 related to bradykinin. It is degraded by angiotensin converting enzyme, and therefore patients who take ACE inhibitor drugs for hypertension or heart failure will have an increase in bradykinin levels. And because bradykinin causes vasodilation and an increase in vascular permeability, one of the potential side effects of ACE inhibitors is angioedema. That's basically swelling and vasodilation like you would would see in inflammation, but it's not occurring from inflammation. It's occurring because someone took an ACE inhibitor drug. Another thing to know about bradykinin is that it's degraded by the C1 inhibitor of the complement system, which I talk about in the immunology videos. This means if patients are born with a deficiency of the C1 inhibitor, they will always have high levels of bradykinin, and therefore they will get recurrent bouts of angioedema. This is a condition called hereditary angioedema. Basically, what's going on here is because there's too much bradykinin around, these patients are developing signs of inflammation like redness and swelling outside of an inflammatory trigger. Now let's talk about the cardinal sign of tumor, which means swelling. This is caused by an increase in vascular permeability that occurs in the setting of inflammation. There are a couple of reasons that vascular permeability increases. First of all, it is sometimes caused by direct injury. If the cause of inflammation is damage to blood vessels, then that will lead to leakage of plasma. There are also many mediators that cause an increase in vascular permeability. These include a couple of leukotrienes. Those are the eicosanoids we talked about earlier. Also histamine, and as I mentioned, bradykinin. All of these substances cause contraction of endothelial cells, which creates gaps between the cells. This occurs in the post-capillary venules, and it's high yield to remember this. If you look at this drawing on the screen here, these are the capillaries, these are the post-capillary venules, and that is where vascular permeability is going to increase. And that happens because two endothelial cells, which might be sitting next to each other and touching, will contract and separate. This will create a gap between them, and that will allow leakage of plasma. Another contributor to the swelling seen at sites of inflammation has to do with changes in oncotic pressure, and it's very high yield for you to understand this for your board exams. In the cardiology section, in the video on regulation of blood flow, I talk about capillary fluid movement. By way of review, within the capillaries, there is a hydrostatic pressure, P sub C, and also an oncotic pressure, pi sub C. The oncotic pressure is created by proteins, especially albumin, and the hydrostatic pressure is basically the blood pressure. There is also, within the interstitial space surrounding the capillary, a hydrostatic pressure P sub I and an oncotic pressure pi sub I. And generally, the hydrostatic pressure is higher in the capillary, which tends to drive fluid movement in this direction. And generally, the oncotic pressure is higher in the capillary, and that tends to resist fluid movement out of the capillaries. What happens in the setting of inflammation is, like we talked about in the last slide, there is leakage of plasma, including protein, out of the postcapillary venules and into the interstitial space. This raises the oncotic pressure in the interstitial space, and this draws fluid out of capillaries into the tissue. So even in parts of the vasculature where the endothelial cells have not contracted to allow for leakage of fluid, there will still be more fluid movement out of capillaries, and that's because the oncotic pressure in the interstitial space at sites of inflammation has gone up. And I've summarized these points on this. Slide, oncotic pressure changes drive fluid into tissue at sites of inflammation, and this is caused by a rise in the oncotic pressure in the interstitial space caused by protein influx. When you evaluate patients clinically, you will often identify tissue edema or swelling as part of a disease process. For example, that swollen big toe we saw earlier from gout is an example of tissue edema, but there are many other disease processes that also lead to the same thing. There are basically two reasons why tissue edema can occur as part of a disease process. The first reason is called an exudate or an exudative form of edema. This is what we've been talking about up to this point in this video. An exudate means fluid leak into tissues that is in form of inflammatory edema from high vascular permeability. And this is what you see in the setting of infections and malignancy. In all these conditions, there are leaky vessels that allow fluid to leak out into the interstitial space and cause swelling. This fluid that is causing the swelling in these situations is said to be an exudative fluid, and the characteristics of an exudative fluid are a high protein content similar to plasma and a high specific gravity, meaning the fluid is concentrated. The reason it has these characteristics is because the cause of the swelling is leakage of plasma, and therefore the tissue edema is close to having the characteristics of plasma. But there is a second reason that tissue edema can occur, and this has nothing to do with inflammation, but it looks the same. It can be hard to tell the two apart. The second type of tissue edema is called a transudate. This is caused when there's very high hydrostatic pressure or low oncotic pressure inside the capillaries. If we look at our drawing on the screen here, remember that the hydrostatic pressure in the capillary drives fluid out into the interstitial space. So if this hydrostatic pressure is very high, that will lead to leakage of fluid, but this has nothing to do with inflammation and nothing to do with an increase in vascular permeability. The same is true if the oncotic pressure in the capillary falls for any reason. Say, for example, the patient is losing albumin from renal disease. That patient will have a low capillary oncotic pressure, and this will favor movement out into the interstitial space. But once again, this has nothing to do with inflammation. So transudates are fluid leaks not due to inflammation, but in contrast to exudates, these fluids that are found in tissue have a low protein content. That's because albumin remains in the plasma and doesn't leak into the interstitial space with the fluid. They also have a low specific gravity. They're very dilute, not concentrated. That's because only water is moving in this direction. It's not carrying proteins and other contents with it. So I've explained to you the difference between an exudate and a transudate because that difference is very important in a common clinical dilemma, and that involves determining the cause of a pleural effusion. Shown on the screen is an X-ray from a patient with a pleural effusion. This patient has a fluid collection in the pleural space surrounding the lungs. Sometimes when you see a patient with this, you don't know what has caused the effusion, and there are a couple of potential causes. The effusion could be an exudate, and if it was, that would mean it might be caused by an infection or malignancy. On the other hand, the effusion could be a transudate, and if that's the case, it could be caused by high hydrostatic pressure, like you see in heart failure, or low albumin, like you see in liver and renal disease. How are you going to tell the two apart when they look the same on X-ray? They just appear like a pleural effusion. Well, the way you do this is by doing a test called a thoracentesis, where you insert a needle and take a sample of the pleural fluid. You then test the pleural fluid for the concentration of protein and lactate dehydrogenase, an enzyme found in plasma and pleural fluid. What you do at that point is you compare the concentration of those substances in the pleural fluid to that in the serum, and the ratio of these two numbers will be close to 1 if the pleural fluid is an exudate. That's because in an exudate, there is leakage of plasma or serum contents, and therefore the pleural fluid concentration is very close to the serum. On the other hand, if it is a transudate, the plasma concentration will be very low relative to serum, and this ratio will be far away from 1, something like 0.1, 0.2, or 0.3. So what you do is you analyze the pleural fluid, then you apply what's known as Light's criteria. Light's criteria says the effusion is an exudate if the pleural protein to serum protein ratio is greater than 0.5, or the pleural LDH to serum LDH ratio is greater than 0.6, or if the pleural LDH is greater than 2/3 the upper limit of normal for the serum LDH. It's not important to memorize these criteria as a med student preparing for step 1, but you should get the general idea, and that is that the makeup of the pleural fluid is going to be close to serum if the fluid is an exudate. On the other hand, it's going to be relatively dilute compared to serum if the pleural fluid is a transudate. Moving on, let's talk about our next cardinal feature of inflammation, and that is dolor or pain. Most important mediator to remember as regards to pain is prostaglandin E2. This is produced in the setting of inflammation and it increases the skin sensitivity to pain. It also causes fever, which we'll talk about in a minute. And an easy way to remember this is that pain and fever are both in the name of PGE2. Pain is right here and fever is right here. So the 5 cardinal signs are the local signs. They occur at the site of inflammation. But in addition to things going on at the site of inflammation, there's a systemic response to inflammation. You know this if you've ever been sick, maybe with a GI infection. Even though the inflammatory process may be in your stomach, you otherwise feel overall sick. Those are the systemic signs of inflammation. We're going to talk about 3 of these now. The first one is fever. The second one is leukocytosis. And the third one is a rise in substances called acute phase reactants. So let's talk about the mechanism of fever. Fever is caused by substances known as pyrogens. All of these substances are capable of increasing the activity of the enzyme cyclooxygenase in the hypothalamus in the brain. And recall that the hypothalamus is the temperature regulatory center of the brain. If we go back to this slide, cyclooxygenase is the enzyme that can convert arachidonic acid into either thromboxanes or prostaglandins, and its activity is increased by substances that are pyrogens. The increase in enzyme activity leads to a rise in the level of prostaglandins in the hypothalamus, and this is what leads to fever. There are a number of pyrogens that occur in the setting of inflammation. Lipopolysaccharide, which is found in many bacteria, is called an exogenous pyrogen because it comes from outside the body. IL-1 and TNF are cytokines. These are produced in the setting of inflammation, and these are endogenous pyrogens because they come from within the body. And so these pyrogens lead to higher levels of prostaglandins in the hypothalamus, and that's what raises the temperature set point. And of all the prostaglandins, the most important one for you to remember as regards to fever is PGE2. And like I told you before, PGE2 also causes pain, and pain and fever are both in the name PGE2. Another systemic sign of inflammation is a leukocytosis or a rise in white count. This is classically seen in the setting of infection, although you can see it in the setting of inflammation from other causes. So a normal white count is less than 11,000. In the setting of infection, it can rise to be as high as 15 to 20,000. In some cases, when there's a raging infection, it can even get as high as 100,000 or rarely higher. This is referred to as a leukemoid reaction because it resembles leukemia. And a very high yield thing to remember for step 1 is that Bordetella pertussis, the bacteria that causes whooping cough, is famous for causing these very high white counts. We don't see Bordetella much anymore because of vaccination, but when it does occur, the white count can get very, very high and mimic leukemia. The cause of leukocytosis is cytokines, especially TNF and IL-1. They trigger cells from the bone marrow to produce more white cells. And the type of white cells that rise in the setting of infection vary with the cause of infection. Bacterial infections usually cause a rise in neutrophils. This is called a neutrophilia. And in the setting of viral infections, there's usually a rise in the lymphocyte count. This is called a lymphocytosis. In the setting of bacterial infection, the leukocytosis often demonstrates a feature known as a left shift. This is part of the normal response to infection. It involves the bone marrow producing more bands, which are immature neutrophils, as well as more neutrophils. To understand this, let's look at this table on the screen. So a normal white blood count might include 10,000 white cells, 55% of which are neutrophils and 5% of which are band forms. In the setting of a bacterial infection, not only will the white cell count go up to 17,000, but the percentage of those white cells that are neutrophils and bands will also rise. This is referred to as a left shift. It gets that name for historical reasons, and it's just part of the normal response to a bacterial infection. For the remainder of this video, I'm going to talk about acute phase reactants. These are all serum proteins whose levels rise in the setting of inflammation, either acute or chronic. Most of them are produced by the liver, and their synthesis is increased usually by cytokines. For most of these, the cytokine that drives their synthesis is IL-6. There are 5 acute phase reactants that are important for you to know, and we'll go through all these in the next few slides. C-reactive protein is usually just called CRP. Liver synthesis of this substance increases in response to IL-6 from macrophages. It has some antibacterial properties. It can bind to bacterial polysaccharides. It can also activate the complement system. And the place this usually comes up clinically is that higher levels are associated with coronary artery disease. Coronary artery disease is an example of a chronic inflammatory process. So patients who have this ongoing their vasculature have higher levels of CRP. So it's sometimes used as a risk factor to identify patients who might have coronary disease. Serum amyloid A proteins are apolipoproteins that have many roles in the inflammatory response. They're important clinically because they cause a form of amyloidosis called AA, or secondary amyloidosis. In the hematology section, I have an entire video on amyloidosis, but for our purposes here, just know that serum amyloid A proteins rise in the setting of inflammation, and therefore in chronic inflammatory conditions, these proteins can deposit and form amyloid, and that's why secondary amyloidosis is seen in the setting of chronic inflammation, like in rheumatoid arthritis, ankylosing spondylitis, or inflammatory bowel disease. Ferritin binds iron. It's the iron storage protein. You can find it in macrophages of the liver and bone, and it's an acute phase reactant, and this has clinical significance. In the videos in the hematology section, I talk about how the level of ferritin goes up in the setting of iron deficiency anemia. However, it's hard to diagnose iron deficiency during an infection or another important inflammatory condition, and that's because in those settings, the high ferritin level may be due to iron deficiency, but it could also be due to inflammation. This has clinical or inflammatory bowel disease. Ferritin binds iron. It's the iron storage protein. You can find it in macrophages of the liver and bone, and it's an acute phase reactant, and this has clinical significance. In the videos in the hematology section, I talk about how the level of ferritin goes up in the setting of iron deficiency anemia. However, it's hard to diagnose iron deficiency during an infection or another important inflammatory condition, and that's because in those settings, the high ferritin level may be due to iron deficiency, but it could also be due to inflammation. Hepcidin is another acute phase reactant. It has some antibacterial properties. It's important clinically because it inhibits iron transport. It binds to something known as ferroportin in cells of the liver as well as macrophages. This leads to iron being trapped inside of cells as ferritin, and this contributes to the anemia of chronic disease, which I talk about in the hematology section. And our last acute phase reactant is fibrinogen. This is factor 1 of the clotting cascade. It promotes adhesions between cells, especially platelets and endothelial cells. And this is helpful in the setting of inflammation, and that's why its level rises in inflammation and why it's an acute phase reactant. Sometimes we see patients clinically who have pain and maybe fever, and we wonder if an underlying inflammatory process is the cause of their disorder. Well, the way you can work this up is by measuring what's known as the ESR, or the erythrocyte sedimentation rate. This is the rate at which red blood cells fall to the bottom of a test tube. Normally, they fall at a rate of 0 to 22 millimeters per hour for men and 0 to 29 millimeters per hour for women. It's a very simple test to perform. You just put a sample of blood in a tube and you determine the rate at which the red cells fall down to the bottom. The reason this is a helpful test clinically in determining that inflammation is ongoing inside the body is because the ESR is increased by acute phase reactants. So we rarely measure the level of fibrinogen or the level of CRP to diagnose an inflammatory process. Instead, we measure the ESR, and that's basically a screening process for whether or not levels of all acute phase reactants are high within a patient's serum. The reason the ESR goes up in inflammation is because the rate at which the red cells sediment to the bottom of a tube is determined by a balance of factors. There are some factors in the plasma that are pro-sedimentation. So all of the acute phase reactants, but especially fibrinogen, increase the sedimentation rate. That's because they cause red cells to stick together, and therefore they fall faster to the bottom of the tube. There are also factors that are anti-sedimentation, especially the negative charge on red blood cell membranes. This tends to keep red blood cells apart and cause them to fall more slowly. When you have high levels of acute phase reactants, especially fibrinogen, the red cells will stick together, they'll fall to the bottom faster, and this will raise the ESR. And this is why the ESR goes up in the setting of inflammation when acute phase reactants are higher in the plasma. So a normal SED rate is less than 30. A very high SED rate over 100 can be seen in some of the conditions listed on this slide. You can see this in endocarditis, temporal arteritis, polymyalgia rheumatica. You can see this after trauma or surgery or in the setting of some malignancies. And some of these conditions, especially endocarditis or temporal arteritis or polymyalgia, can present with nonspecific symptoms where the diagnosis isn't clear. So identifying a very high SED rate helps to narrow down the differential. Another famous cause of a high SED rate is anemia. The reason for this is because the sedimentation of red cells is slower when you have more red cells. The red cells basically repel one another and cause the sedimentation to go more slowly. So when you have less red cells in the setting of anemia, there's less red cells impairing one another's sedimentation rate down to the bottom of the tube, and therefore the ESR goes up. And then finally, renal disease is known as a cause of an increase in SED rate. Some of this is because many patients with renal disease have anemia from low EPO levels, but there are other reasons. There are a couple of situations that can lead to a very low ESR. Remember, normal is less than 30, but very low, like less than 5, is unusual. This can happen if there's a low level of fibrinogen in the serum. Remember, fibrinogen is one of the things that generates the SED rate and causes red cells to stick together and to sediment down to the bottom of the tube. Heart failure is also often listed as a cause of a low ESR, although this is controversial. It's not clear this definitely happens, and the mechanism of a reduced ESR in heart failure is unclear. Second cause of a very low ESR is anything that causes the red cells to have abnormal shapes. So you can see this in sickle cell anemia, spherocytosis, and microcytosis. Polycythemia can cause a very low ESR. This is the opposite mechanism that we discussed on the last slide for anemia. And the important thing to know clinically about all the things listed on this slide is that they can lower the ESR even though there may be inflammation going on. So a person who has an inflammatory process but has sickle cell anemia may not have the normally increased ESR that you would see, and that's because there is something going on to raise the ESR, that's inflammation, but something going on to lower the ESR, that's an abnormal red cell shape. And then finally, there are a couple of substances known as negative acute phase reactants. The level of these substances fall in the setting of inflammation. Their synthesis is inhibited by cytokines. The most famous one is albumin. You will see this in the hospital and the ICU all the time. Patients with a chronic inflammatory process will have low albumin levels. Two others worth knowing are transferrin, which is involved in iron metabolism, and transthyretin, which is one of the substances that contributes to senile amyloidosis. And that concludes our video on inflammation principles.